Welcome to another CCNAPI webinar entitled World Heart Day 2023, A Nurse's Role in Acute Coronary Syndrome. I am Dennis D. Tawataw, an ICU nurse supervisor from the President Ramon Magsaysay Memorial Hospital, Iba, Zambales, the moderator for today's event. This is a 4-hour webinar that aims to enhance nurses' awareness in recognizing life-threatening episodes that are cardiac in nature and their complications if not properly treated, assessed, and managed accordingly. Furthermore, this educational activity shall provide the participants with a thorough and systematized approach in assessing and managing patients based on the accepted guidelines from both local and international standards. The program specifically aims to discuss frequently encountered arrhythmias that warrants regular assessment to minimize complications, explore both nursing interventions and pharmaceutical regimen in treating arrhythmias, compare common clinical manifestations of ACS from signs and symptoms that are not cardiac in origin, provide a systematized approach in assessing clients with cardiac events or who are potentially at risk, and explain treatment guidelines in management of ACS based on American College of Cardiology and American Heart Association. Friends, this webinar is applied for CPD credit units to the PRC Board of Nursing. So we will now tackle the first topic entitled Arrhythmias and their management. Our first ever speaker is a graduate of Bachelor of Science in Nursing at the Far Eastern University, Manila. He is currently taking his Master's of Arts in Nursing, major in Medical Surgical, at the Arellano University, Tolentino Caico Memorial School, Graduate School of Nursing. Currently, he is the Vice President of the Critical Care Nurses Association of the Philippines. He is also a certified emergency neurological life support instructor, a basic life support and advanced cardiac life support American Heart Association instructor. His field revolves around critical care nursing and cardiovascular nursing. Lastly, he is the current president of the Southeast Asian Federation of the Critical Care Nurses Association. So, ladies and gentlemen, to share his insights on arrhythmias and their management, a virtual applause to John Christian M. Agustin, RN. Mr. Agustin, the virtual stage is yours.
All right, so good afternoon and thank you for that kind introduction, Mr. Tawataw. So allow me to share my slide, please. All right. So thumbs up na nga po sa mga nakakita ng slides ko. Okay, so thank you, Mr. Tawataw, kung ikaw lang po ang nag-respond. So again, welcome to this afternoon. We're celebrating World Heart Day, which is celebrated yearly at during September 29. So my topic will revolves around approach to basic arrhythmias. So again, my name is JC Agustin and I'm the Vice President of CCNAPI. So brief disclosure, I might mention some name or brand. I am not connected with them. The product or the medications that I will be mentioning are for educational purposes only. So this will be my objectives or the participants' learning outcomes. First is to deepen the critical care knowledge and understanding on basic arrhythmias. And second, recognize life-threatening dysrhythmias and plan corrective actions based on presenting clinical manifestations. So in line with our theme the day, I would like to start my presentation with some facts about cardiovascular disease. So can you please type down in the chat box, ano kaya tong 17.9 million, no, na related sa cardiovascular disease? Or anyone from the group have an idea what is the relevance of this number? So thank you, Miss Galion. Okay, this is actually according to the World Health Organization, 1 in 3 deaths is due to cardiovascular diseases. So that's equivalent to 17.9 million. So how about this number? 99,700. Diagnose, okay. Ano pa kaya? Anything else? Any idea? 99,700 in relation to cardiovascular disease. Actually, this is the number of deaths in our country. No, in the year 2020, according to the Philippine Statistics Authority, it tallies 17.3% of total deaths, making it the top leading cause of mortality in the Philippines and worldwide. Okay, so a little trivia about our topic. Which day of the week do more people have heart attacks? You may type the answer in the chat box. Nung araw kaya maraming nagkakaroon ng heart attack? Araw po, nung araw, so weekend, early morning, Friday, okay? Ano pa kaya? Okay, so congratulations, Miss Kathleen, you got it right. No? So according to researches, Monday, no? Monday ang pinakamataas na heart attack na natatali. Actually, Monday morning. It seems that Monday morning stress can elevate cortisol level. Cortisol, also known as your stress hormone. So there's an increased level of cortisol that can prompt blood vessels to constrict, which can cause built-up cholesterol plaque to dislodge and obstruct blood flow to the heart. So before we move to our main topic, which is arrhythmia, may I see a show of hands who are assigned in a critical care area, emergency room, ICU, post anesthesia care unit, currently assigned, or sino yung mga na-expose before? Okay. Isa, dalawa, tatlo, apat. You may raise your hand or you may use the chat box. Okay. So 6 ang nag-raise tapos I don't know kung na doble. Okay, so sa mga hindi nagtaas, no, how about who among you guys doesn't have much experience handling patients on a cardiac monitor or hooked to a cardiac monitor? Sino po sa inyo yung medyo nasa ward, nasa assigned sa OPD, nasa call center, na hindi masyadong nakakahawak ng pasyenteng naka-attach sa cardiac monitor? Again, can I see a show of hands? Okay, good. So, okay, meron pong tayong isa. Okay, that's fine, no? So, because I'm going to discuss naman from, from basic to interpretation. So, moving forward to our topic, which is arrhythmia. The term arrhythmia refers to any problem in the rate or rhythm of a person's heartbeat. During an arrhythmia, the electrical impulses may be too fast, too slow, or erratic, causing an irregular heartbeat. When the heart doesn't beat properly, it won't pump blood effectively. Always remember that. So when this happens, the lungs and the brain and all other organs can't work properly and may shut down or get damaged. History and physical examination may detect an arrhythmia and suggest possible causes, but diagnosis requires a 12-lead ECG, or less reliably, a rhythm strip, or your long lead 2, preferably obtained during symptoms to establish the relationship between the symptoms and the cardiac rhythm. So here are the different tests or different types of your ECG. A resting ECG carried out while the patient is lying down in a comfortable position. We also have your stress test or exercise ECG, which is done while the patient is running or exercising using a stationary bike or a treadmill. And lastly, we also have your ambulatory ECG halter, or we also sometimes call this your halter monitoring. The electrodes are connected to a small portable machine worn by the patient. Basically, it will record the heart rhythm of the patient for 24 hours or more, or depende sa doctor's or physician's discretion. The type of ECG that will be ordered will depend on the symptoms being presented and the heart problem being suspected. For example, an exercise ECG may be recommended if the symptoms are triggered by physical activity, whereas an ambulatory ECG may be more suitable if the symptoms are unpredictable and occur in random short episodes. This can be done in an outpatient and or inpatient basis. The ECG is approached systematically. Calipers measures interval and identify subtle irregularities. The key diagnostic features are your rate and regularity of your atrial activation, the rate and the regularity of your ventricular activation, and the relationship between your atrial and ventricular activation. Other available tests are your thallium stress test, or also known as your nuclear stress test. The patient will receive a dye via intravenous line. This allows the cardiologist to view the images of the heart using a special camera. Another is your stress echocardiogram. This is the same as basically same with your exercise ECG test, but a healthcare provider will hold a transducer against the chest of the patient. This transducer device will create sound waves that makes the moving pictures of the heart. Most arrhythmias happen because of an issue with the heart's arteries, valves, or muscles. Other factors likely to consider are your age, the chances going up as you get older, the genes, if a close relative had an arrhythmia, or some type of heart disease, of course, ika nga namana mo siya. Lifestyle, alcohol, tobacco, and recreational drugs can raise your risk. Consuming drinks that are high in caffeine will also trigger arrhythmia. Medical conditions such as high blood pressure, diabetes, low blood pressure, obesity, sleep apnea, and autoimmune disorders are among the conditions that may cause heart rhythm problems. Having a BMI of higher than 30 is also an issue. Of course, coronary artery disease, irritable tissue in the heart due to genetic or acquired disease, changes in the heart muscles due to specifically pag may cardiomyopathy, valve disorders, electrolyte imbalance as well can also lead to different types of arrhythmias, and injury from heart attack, and healing process after a heart surgery. Of course, all of those will be your predisposing factors. Arrhythmia and conduction disturbances may be symptomatic or cause palpitations, symptoms of hemodynamic compromise like dyspnea, chest discomfort, syncope. If we remain unchecked, it could also lead to serious and life-threatening complications like stroke, heart failure, and even death. So let's now have a quick review of what makes a normal sinus rhythm. So as you can see in your slide, the resting sinus heart rate in an adult is usually 60 to 100 beats per minute. Slower rates occur in young adult, particularly if the patient or the client is an athlete and during sleep. Faster rate or tachycardic occur during exercise, illness, periods of intense emotion through sympathetic neural and circulating catecholamine drive. Normally, a marked diurnal variation in heart occurs with lowest rate during before early morning awakening. So ito yung pinakamababang heart rate na nare-record. Usually nakikita to sa Holter monitoring. Ideally, rhythm should be regular, but a slight increase in rate during inspiration with a decrease in rate during expiration, we call this your respiratory sinus arrhythmia, is also considered normal, which is common in the elderly and healthy children. Most cardiac electrical activity is represented on the ECG, although SA node, AV node, and Purkinje depolarization do not involve enough tissue to be detected. Here are the waves, the different waves and complexes commonly found in an EKG. Your P wave is characterized by an upright, smooth, well-contoured wave. It is the first positive deflection in your ECG, so always look first with for your P wave. The P wave represents atrial depolarization. The QRS complex represents ventricular depolarization, and the T wave represents ventricular repolarization. So depolarize, work, repolarize, rest. So repolarize, since R siya, rest. PR segment reflects the time delay between atrial and ventricular activation. The PR segment also serves as the baseline of the ECG curve, or we call this your isoelectric line. So let me help you with that. So again, the PR segment, this is very important because this will mark as your baseline for your ST segment. So ideally, your ST segment should be aligned with your PR segment. The PR interval, so that's from your P to Q wave, is the time from the beginning of the atrial activation to the beginning of your ventricular activation. Much of this interval reflects slowing of the impulse transmission in the AV node. So basically, your PR interval measures the travel time of the impulse from your SA node to your ventricles. The normal PR interval, it's 0.12 to 0.20 seconds. Next is your QRS complex. So again, your QRS complex signifies ventricular depolarization. It could be narrow QRS complex. We can measure this using the difference between the Q wave and the S wave. So titignan natin kung gaano siya kalapad or gaano siya kapayat. Ideally, the width of your QRS complex should be within 0.12 seconds or 3 small boxes to considered to be narrow. So again, the normal is a narrow QRS complex. Wide QRS complex is more than 0.12 seconds. That signifies a ventricular origin or a supraventricular rhythm conducted with an intraventricular conduction defect, or with ventricular pre-excitation that is usually present in the if the patient is diagnosed with your Wolff-Parkinson-White syndrome. ST segment, this measures the time interval between your ventricular depolarization and ventricular repolarization. Again, your ST segment should be aligned with your PR interval. The R to R interval, so the R, then another R interval, that measures the time between two QRS complex representing the ventricular rate or the patient's heart rate. The QT interval, QT, is measured from the beginning of the Q wave to the start of your, or to the end of your T wave. Okay, the normal QT interval is controversial. Multiple normal durations have been reported. In general, the normal QT interval is below 400 to 440 milliseconds, or 0.4 to 0.44 seconds. Women have longer QT interval than men, and lower heart rates also results in a longer QT interval. We can basically classify arrhythmias based on the heart rate, if it's tachy or bradyarrhythmias. Bradyarrhythmias result from decreased intrinsic pacemaker function or presence of blocks in conduction, and principally within the AV node or the Purkinje system. Most tachyarrhythmias are caused by re-entry, or some result from enhanced normal automaticity or from abnormal mechanism of automaticity. Us practitioners will have a better understanding of arrhythmias by recognizing the rhythm if it's a disturbance in impulse formation or conduction, which I will further explain later. And lastly, we could also classify arrhythmias based on its prognosis. However, please take note that we shouldn't base an arrhythmia, we should base the prognosis based dun sa interpretation natin, no? But the outcome or the effect hemodynamically to our patient. So here are some common arrhythmias. ECG diagnosis of bradyarrhythmias depends on the presence or absence of P waves, morphology of the P waves, and relationship between P waves and the QRS complex. The most common bradyarrhythmias are your sinus bradycardia, presence of AV, and heart blocks. While tachyarrhythmias may be divided into four groups defined by the QRS complexes. If the QRS complex is regular or irregular, and the morphology of your QRS complex is wide or narrow. Irregular and narrow QRS complex tachyarrhythmias includes the following three arrhythmias: your atrial fibrillation, which is a continuous, irregular morphologies, continuous, irregular in timing and morphology. The morphology of your P wave varies. No? Minsan nga hindi natin makita, sobrang liit kasi fibrillatory na to. We also have your atrial flutter with varying AV conduction. And lastly, we have your multifocal atrial tachycardia, in which presents with three different pictures of your P waves. Next, we have your irregular wide QRS complex tachyarrhythmia. So basically, the three arrhythmias I mentioned: atrial fibrillation, atrial flutter with, and your multifocal atrial tachycardia with the presence of bundle branch block that will cause the widening of your QRS complex or presence of your PVCs, and of course your this torsa de pois, yeah, the irregular wide or your polymorphic VTAC. Next, we have your regular narrow QRS complex tachyarrhythmia. So number one, we have your sinus tachycardia. We also have your SVT, your junctional tachycardia, your atrial tachycardia. Atrial flutter can also be regular. No, it depends on the AV conduction ratio. Okay? And lastly, we have your regular and wide QRS tachyarrhythmias. So basically, it includes your SVT, your junctional tachycardia, na merong bundle branch block, and your monomorphic VTAC. Those are the types of tachyarrhythmias based again if the rhythm is regular or irregular, and if your QRS complex are wide or narrow. Another manner on how we can distinguish arrhythmia is by understanding its specific mechanism by which an arrhythmia is generated falls into one of the two categories, either as a disorder of impulse generation or a disorder of the conduction system. So thinking about those words mean the disorders of impulse generation means that the excitation of the heart is initiated inappropriately, whereas disorders of the conduction means that the normal propagation or the travel of the impulse is corrupted, no? That doesn't follow the usual organized route. Disorders of impulse generation are created by changes in automaticity, meaning changes in pacemaker activity, presence of ectopic beats, or by extra triggered activity. Whereas disturbances of impulse formation are created by autonomous reentrant circuit or by a blockage of the conduction system. Disorders of impulse formation affects the heart pacemaking process. In the normal heart rate, in the normal heart rather, the heart rate is controlled by the automaticity of the SA node, but there are situations when the normal pacemaking is lost, which could lead to the different disturbances in your screen. So pwedeng mag-tachycardic ang patient, pwedeng presence of ectopic beats if there's an irregular, if there's a irritable foci in the Purkinje fibers or in the junction cells, no? Or pwedeng there's a reentrant circuit in the atria producing a flutter and fibrillatory wave. So those are your disturbances in impulse formation. For disorder of conduction affect how a wave of excitation moves through the heart, deviating from the normal path of electrical activity that creates a normal heartbeat and a productive cardiac output. So a patient who has a disorder of impulse formation may have additional activity that is initiated elsewhere or activity that follows a different route through the heart. So imagine nasa ano kayo, ano bang tawag nito? Nasa EDSA, no? So, one way lang dapat ang daan ng conduction system. The problem is, dun sa special road, dun sa pang-bus lang, may mga dumadaan na motor, may mga dumadaan na hindi ganun ka-emergency. So, basically, same principle with the disturbance in conduction. Again, disturbance in conduction can be classified into according to three main anatomical areas. There's a block within the SA node or atria. There's a block between the atria and ventricles. And lastly, there's a block within the ventricles rather. Lastly, we could classify the tracings based on their known or expected prognosis, specifically its effect hemodynamically. Minor doesn't need immediate concern because they do not affect the circulation, nor do they warn of development of more serious dysrhythmias. Major dysrhythmias will require treatment because they tend to disturb either reducing the pumping mechanism of the heart or it is a sign of an onset of a lethal dysrhythmias. Lastly, we have your death-producing or fatal dysrhythmias, which requires immediate resuscitation and management to prevent death. So again, not all arrhythmias need acute intervention. Some are relatively benign and as such are best not addressed in the acute setting. For instance, atrial fibrillation should not be addressed in the acute setting unless very recent in origin. Other arrhythmias, while looking dramatic, are still managing to perfuse the brain and are better than the alternatives that might result from an attempt to correct them. An approach to arrhythmias that are still perfusing is to provide support with oxygenation and ventilation while observing the patient. The alternative approach of more active management sometimes runs the risk of creating a situation that is worse than the current one. The criteria for deciding that an arrhythmia needs intervention vary with the situation and the support available. Consciousness level is probably the best marker of perfusion in this situation. Although blood pressure has always been considered as a key marker, it is probably less useful if your patient is unconscious. Okay, so another is your mean arterial pressure, which is a key measure of perfusion, but unfortunately, it is not well related to measured blood pressure, particularly at the extremes of the heart rate. There are several types of medications used to treat arrhythmia, including beta blockers, your calcium channel blockers, your anti-arrhythmic drugs. Beta blocker medication slows down the heart rate and reduce the risk of arrhythmias, while your calcium channel blockers are used to relax the blood vessel and reduce the risk of blood clots, while your anti-arrhythmic drugs are used to restore the heart's normal rhythm. Treatment for arrhythmia depends on the type, severity, and underlying cause. Other arrhythmias may require an implantable device such as pacemaker or defibrillator Other patients will also require ablation therapy, which involves destroying the abnormal electrical pathways in the heart. And in some cases, a procedure may be needed to restore the heart's normal rhythm. The hardest decisions regarding intervention are for the patients who, while conscious, are obviously not perfusing well, and for whom the consequences of interventions may include an even worse rhythm. So, for example, a complete heart block with a junctional escape rhythm may generate perfusion that, although not optimum, is adequate. So if in doubt, an approach of maximizing oxygenation, optimizing preload, and adopting an attitude of optimistic expectancy is the safest strategy. Here are some arrhythmias that are considered non-emergent in nature. All of this will be discussed in my succeeding slides. So again, we have your sinus tach, sinus brad. We have your sinus arrhythmia, wandering pacemaker, your premature atrial contraction, PJC, and infrequent PVC. Again, all of these are considered minus dysrhythmia. So you are a nurse taking care of a 66-year-old male for an executive checkup. You hooked the patient to an ECG machine and revealed this tracing. Can you please identify the rhythm in your screen? You may type the answer in the chat box. I'll give you 15 seconds. Okay, parang tatlo lang po ang sumagot. Nasaan po ang 38? Okay, parang wala pa pong nakakakuha ng tamang sagot. I'll give you additional 5 seconds. Okay, so I lied. Again, ginulo ko, nanggugulo lang ako. So again, the correct answer is letter B. It is sinus bradycardia. Why? Because as you can see, we have 1, 2, 3, 4, 5 QRS complexes. Multiply that by 10, you will have a heart rate of 50 beats per minute. Again, to know the heart rate of the patient, you need to have a 6-second strip. So this is a 6-second strip. Count the QRS complex times 10. That will be that's an estimate heart rate. So we have 50 beats per minute. That's your sinus bradycardia. So it is a skill to properly identify these arrhythmias. But what is more important is to know what will be the ideal approach. So what will you do next? Again, I'll give you 15 seconds. Letter A, just continue observing. Letter B, give fluid. Letter C, I need to refer this. And letter D, I will prepare temporary pacemaker. All right, so thank you for your cooperation. Again, all of you got the answer correct. The correct answer is letter A. So we just need to continue observing. Of course, you need to get the vital sign as well. Correlate the heart rate with your blood pressure. Okay? So ask the patient if meron ba siyang naramdaman for any signs and symptoms. And of course, you need to get the history of the patient, get the baseline heart rate, and if the patient is taking maintenance, specifically your beta blockers. So again, this is sinus bradycardia. The physiology of sinus bradycardia is due to increased vagal tone. It can be physiological in athletes. Usually, sinus bradycardia with a heart rate of 50 to 60 beats per minute is asymptomatic, though it can lead to orthostasis or dizziness if pathological, and no treatment is required unless pathological. So this is the algorithm from the American Heart Association regarding the management of sinus bradycardia. So I believe you're familiar with this, but allow me to share it lang. So again, assess appropriate for clinical conditions. Okay, so identify and treat the underlying cause. You need to maintain patient airway patent, give oxygen if the patient is hypoxemic, attach the patient or a cardiac monitor, hook an IV. You may also get a 12-lead ECG, and of course, consider possible hypoxic and toxicologic causes. After which, you need to check the patient if he is stable or unstable. So, paano natin malalaman kung stable or unstable ang patient? So, you need to check the following. Is the patient hypotensive? Is the patient, how's the level of consciousness of the patient? Is there a presence of shock? Is there a presence of chest pain? And acute heart failure. If the patient is asymptomatic, meaning wala ni isa, you just need to observe the patient. But if the patient is presenting with signs and symptoms, then this will be your management. Medications, we have three: your atropine, your dopamine, and or your epinephrine. Of course, you may need to you may also consider attaching the patient, of course, with the doctor's order, to a transcutaneous or your temporary pacemaker. After which we can need to consider referring to a specialist, to a cardiologist or specialist for possible transvenous or permanent pacemaker insertion. So this is the dosing as recommended. Your atropine can be given 1 milligram every 3 to 5 minutes, maximum of 3 milligrams. Don't be confused kasi yung lumang, if I'm not mistaken, before it's 0.5 to 1. Ngayon, 1 milligram na. The dopamine IV infusion, usually it's 5 to 20 microgram per kilogram per minute. You may titrate accordingly until mag-respond the patient. For your epinephrine IV infusion, it's 2 to 10 microgram per minute. But with your epinephrine, you may consider or you may check first with your hospital policy, because some hospital doesn't give epinephrine IV infusion via peripheral line. Okay. So same principle with arrhythmias. With your, as I mentioned earlier, not all bradycardias require treatment. If there are no symptoms or and a person does not have an underlying heart condition, a slow heart rate can be no cause for concern. Treating the underlying cause, for example, a heart attack with a blocked blood vessel or severe infection such as sepsis, may temporarily cause a slow heart rate. Treating the infection or the blockage should restore the heart to its normal rate. Treating the arrhythmia when damage to the heart's electrical system causes a dangerously slow heart rate, or when the heart rate is slow enough to undermine health, a physician may recommend using an implantable device such as pacemaker. Implanting this device requires, of course, surgery. Management of bradycardic usually revolves around the acronym ATDE, your atropine, transcutaneous pacemaker, dopamine, and epinephrine. So always remember, dopamine IV infusion, 5 to 20 microgram per kilogram per minute, while your epinephrine, it's 2 to 10 microgram per minute. So hindi tayo weight-based. Okay. The physician on board ordered to hook the patient on cardiac monitor. So same patient tayo. What is now the current ECG tracing of our patient? I'll give you 15 seconds. Is it letter A, atrial fibrillation? Letter B, presence of premature beat? Letter C, presence of heart blocks? Or letter D, this is sinus arrhythmia? Okay, so I believe all of you answered letter C. Okay, so the correct answer is letter D. It's sinus arrhythmia. So what is sinus arrhythmia? Again, yung sinus arrhythmia is usually considered normal sa elderly and children with a healthy heart. Usually asymptomatic, and considered normal. The changes in regularity is brought upon by inhalation and exhalation process, as you can see in your screen. So this is the normal heart rate of the patient. During inhalation, because of the expansion of the lungs, may mga naiipit na ugat causing an increased heart rate but not tachycardic, no? An increased heart rate. And then during expiration, nade-deflate na yung lungs, so yung ugat medyo nakakagalaw na siya, causing a slowing down of a heart rate. This is your sinus arrhythmia. Okay, basically, this is your sinus tachycardia. All parameters are normal. So we have a regular heart rhythm, heart rate more than 100 beats per minute. We have a we have a normal P wave, normal PR interval, a normal or narrow QRS complex. So ang mali lang sa kanya, the heart rate. So what will be your best course of, what will be your next intervention? So you have a patient, after attaching the patient to a cardiac monitor, sinus tach. Please take note, you have 2 correct answers here. So I'll give you 15 seconds. Mukhang nalito kayo. This is a different patient, ha? This is a different patient dun sa nagkaroon ng sinus arrhythmia. This is a new patient. After attaching the patient B to cardiac monitor, ECG revealed sinus tachycardia. What will you do next? So of course, we need first to assess the patient. So it's letter A and letter B. Okay, reassess after a few minutes, and of course you need to include pain, vital signs and pain. Why? Because usually increased blood pressure, pain, febrile episode can lead to tachyarrhythmia. The sinus tachycardia, it's usually not cardiac in nature, or the etiology of this arrhythmia is not cardiac in origin, but a symptom of an underlying cause. So you need, kunyari nasa emergency room ka, nag-sinus tach ang patient, no? You need to ask the patient to rest, then recheck after few minutes. Okay, kasi hindi na sinus tachycardia, despite the heart rate is more than 100 beats per minute, it can still perfuse the organ. Okay, so here are some pictures of the 3 premature beats that I mentioned a while ago. Your PJs, premature atrial contraction, premature ventricular contraction, and your premature junctional contraction. So kindly identify which beat is shown in your screen. Is this letter A, premature atrial, letter B, premature junctional, or is this an escape beat, or letter D, premature ventricular contraction? Okay. Okay, so congratulations guys. This is a premature atrial contraction. So what's ang hallmark presentation ng premature atrial contraction? As you can see in your screen, we have a P wave, QRS, T wave. Biglang nagkaroon ulit tayo ng P wave, QRS, and T wave. So if you're going to measure the regularity of your R to R interval, the second beat or the second QRS complex, lumabas siya ng mas maaga. So this is a premature beat. So knowing that this is a premature beat, we need to identify if it's saan galing yung ectopic foci. Sino ang nag-create ng ectopic foci? Si atrial ba? Si junctional ba? Or si ventricles ba? Because again, we have 3 pacemakers. So since this is a P wave, upright P wave. So this is a premature atrial contraction. How about this one? So we have a regular rhythm, regular rhythm, regular. Uy, naging irregular. Again, this tracing or this wave, there's QRS complex na paaga. So this is a premature beat. Regular again, another premature beat. So what type of premature beat is this? Who created? Sino ang may sala sa tatlong pacemaker natin? So as you can see, we have a narrow QRS complex, absent P wave. If that's the case, this is your junctional contraction. Premature junctional contraction, absent P wave, and a normal looking QRS complex. If si ventricular contraction ang nag-create ng impulse or si Purkinje fiber ang nag-create ng impulse, you will see a wide, abnormal looking QRS complex. This is regular, this is wide. Again, premature contractions are extra heartbeat that begins in one of the heart pacemaker outside the SA node. It could be from the atria, the junction cells, or created by the junction cells or created by your Purkinje fibers. These extra beats disrupt the regular heart rhythm, sometimes causing a sensation of a fluttering or a skip beat in the chest. So is this dangerous? Not really. Okay, not really. Of course, the patient the doctor may give an antiarrhythmic, but hindi naman siya life-threatening. Wag lang maging frequent. So this is your wandering atrial pacemaker. This arrhythmia is characterized by 3 different pictures of P wave, as you can see in your screen. We have your present P wave, upright P wave. We have an absent P wave. And lastly, we have, the second is inverted and the third is absent. So 3 different pictures of P wave. This is wandering atrial pacemaker. Sir, I think this is a parang medyo rare, no? Hindi ba dapat nakakatakot siya? No. Because the heart rate is still within the normal range of 60 to 100 beats per minute. So regardless who created the impulse, the work of the ventricles is still within the normal function, which is 60 to 100 beats per minute. So in terms of perfusion, the heart is perfusing well regardless kung saan galing yung kuryente. Kung ang kuryente ba ay galing sa puso, ang kuryente ba nito ika nga sa bahay natin galing ba tong Meralco, nakitap ba tayo sa kapitbahay, regardless kung kanino galing ang kuryente, nagpa-function pa rin ng normal ang ventricles natin. So the SA node fires, creating a positive QRS complex. Here's sa second picture, the AV node fires the impulse, producing an inverted P wave or a flat or absent P wave. Now, here are some common arrhythmias that usually present with signs and symptoms or may lead to hemodynamic instability if and left treated. I'm not going to discuss everything. I'm just going to give you the most common. Okay, so please identify the strip in your screen. Is it junctional rhythm? Is it sinus bradycardia? Is it first degree AV block? Or there's a complete AV dissociation? I'll give you 15 seconds. All right, so okay, so I think majority got right. This is your first degree AV block. So as you can see in your screen, we have 1, 2, 3. We have 5 beats per minute, so the heart rate of 50 beats per minute. Your rhythm is still regular. We can see a P wave, a normal P wave, a normal QRS complex, a normal T wave. The ST segment is also isoelectric, but the problem is the PR interval, it's quite long. No, it's quite prolonged because the normal PR interval, it's 3 to 5 small boxes. Pero dito, mabot tayo ng 8. So it's a constant, prolonged PR interval. That's your first degree AV block. Okay? Usually caused by increased vagal tone or conduction impairment or due to medications. Generally, medications like your adenosine can lead to first degree AV block. Kunyari, nag-SVT ang patient, then you gave adenosine, could convert to first degree AV block. Usually, it is asymptomatic, but can cause dizziness. Okay? Again, no need to treat unless if the AV block is progressing. The hallmark presentation, it's constant prolonged PR interval. How about this strip? Can you identify? Can you interpret? I'll give you again 15 seconds. Okay, so 1, 2, 3, 4. Parang 5 lang po ang sumagot. And you answered Mobitz 2 or second degree type 2. So Miss Galion, congratulations, you got it right. It's Mobitz 1. Okay, it's Mobitz 1 or second degree type 1. So what's the presentation of your second degree type 1? There's a progressive lengthening of your PR interval. There's a pattern, normal, humaba, mas humaba, then a drop beat. So we have a normal, prolong, mas naging prolong, and then a drop beat. Then it will go back again to normal, prolong, mas nagprolong, then a drop beat. That's your second degree type 1. How about this one? Isa lang po ang sumagot. Miss Shazer Arabani? Or iisip pa po yung iba? Sige, I'll give you additional 10 seconds. Okay, the correct answer is letter B. That's your second degree type 2. So again, we have your first degree AV block, second degree type 1 or type 2. Okay? So in Mobitz 1, there's a progressive lengthening of PR interval. There's a pattern. While in Mobitz 2, there's a randomly drop QRS complex in an ECG. Okay, so another thing to remember that this is second degree type 2. Your QRS complex is still dependent with your P wave. But not all P waves can create a QRS complex. So again, lahat ng QRS complex may katabing P wave, but not all P wave may katabing QRS complex. That's your second degree type 2. Also, second degree type 2, you have an irregular heart rhythm, usually. Okay? So is this a AV dissociation? Is this an hybrid AV block? Is this a third degree AV block or complete heart block? Ay, dalawa pa lang po. Okay, the correct answer is letter C. and letter D. C and D, because your third degree AV block, that's also called your complete heart block. Okay, so the mechanism of your AV dissociation naman is a umbrella term. So don't be confused. AV dissociation is an umbrella term. Under your AV dissociation, basically you have your first degree, second degree, third degree. Okay? That's your AV dissociation. Pag sinabing complete AV dissociation, basically that's your complete heart block, and that's also your third degree AV block. Okay? So pare-parehas lang naman yung terms na yan. So there's a lack of conduction of atrial impulse to ventricle, leading to independent contractions. As you can see, we have a regular R to R interval. We also have a regular P to P interval. So there's a complete AV dissociation. There's no more communication between your between your atria and your ventricles. May sarili na silang mundo. Okay? So, recap. I know some of you got confused with the type of heart blocks. So, recap. Balikan natin. Always remember, heart block is a love story. Your first degree AV block, your second degree type 1, type 2, and complete heart block, love story yan. Relationship. Si P-wave si guy, si QRS complex si girl. So, they have a constant, okay ang relationship nila. They have a constant communication. Hindi nagbabago ang PR interval. However, the problem is distance. So your first degree AV block is long distance relationship. Second degree type 1. Okay? Second degree type 1, ito yung medyo nasa rocky stage sila. Okay? So, sweet sila, kakabati lang nila, nag-away, hindi nagparamdam ngayon si girl ng 1 day, nag-away ulit, hindi na naman nagparamdam si girl ng 2 days, then they break up na. After a week, nagkabalikan, sweet ulit sila. So sweet, away-away break, sweet, away-away break. That's your second degree type 1. For your second degree type 2, okay, constant nagde-text si guy. However, si girl, bihira na mag-reply. Good, can we go out? Dito tayo. Hindi nag-reply si girl. Hi, hello, nag-reply. Good morning, good day, I miss you, walang reply. So, si second degree type 2, si guy, madalas nagpaparamdam, pero si girl, hindi, pili na lang ang nire-replyan. Your complete heart block, by the word itself, complete, there's a complete AV dissociation. So si guy, madalas lumabas, going out. Si girl, going out na rin. But there's no more communication between them. That's your complete heart block. Okay? Now, this is a hybrid AV block. As you can see, this is a second degree AV block, 3:1. What do you mean 3:1? 3 P waves, 1 QRS complex. Okay, so this hybrid AV block will produce an very slow ventricular heart rate. Unlike third degree AV block, hybrid AV block still has some relationship between the P wave and the QRS complex. Usually, your high-grade AV block may result from either second degree type 1 or second degree type 2 AV block. Management of AV blocks. You can see in your screen. For your first degree AV block and second degree type 1, you may use the acronym ATDE. So same with your sinus bradycardia, atropine, transcutaneous, DOPA, epi. But for second degree type 2, complete heart block and hybrid, the management should start first with your pacemaker and do not give atropine, because your atropine could lead to ventricular arrhythmias. Okay? Now, sorry, dapat wala to. Dapat wala tong yellow sa gitna. So I'll give the answer. This is your sinus block. So nagkaroon tayo ng irregularity because there's a part of your tracing na walang na-create na impulse. However, if we're going to put here a QRS complex, your tracing now will be regular. Okay, so kung mag-i-imagine tayo, maglalagay ng QRS complex dito sa gitna, then your tracing will be fine. It will be completely normal. So we call this your sinus block. Okay, so here are the different pictures of your sinus block. We have your sinus block, sinus pause or arrest. They're basically the same. So sinus block looks very much the same as sinus arrest with one important distinction. The duration of the pause with sinus block is in a direct multiple of the R to R interval of the underlying rhythm. Sinus arrest does not have this specific feature. So again, so we have 1 here. Kunyari, meron tayong 10. The R to R interval, it's 10 small boxes. Example lang, kunwari. So sinus block, we have 20 small boxes. So again, pag maglalagay tayo ng QRS in between, we have a regular heart rhythm na. For sinus arrest, usually more than 2 or 3 times. So we have normal heart rate is, sabihin natin, 10 small boxes. Okay, sinus arrest, more than 3 small boxes. Okay, so sinus arrest occurs when there's a sudden absence of electrical activity initiated by the SA node. This results in a pause in the electrical activity seen on the tracing. Usually, the most common patient na nagkakaroon ng sinus block or sinus arrest are the elderly performing Valsalva maneuver. Okay? Remember, no electrical activity, no depolarization, and no contraction. Hence, a drop in blood pressure. The longer the pause, the further the blood pressure will drop. So if you have a patient with sinus arrest, you may check the medications being given. Usually may mga beta blockers yan, baka kailangan i-stop. And patient na may sinus arrest, candidate for permanent pacemaker insertion. Again, so while the most common intrinsic factor leading to sinus node dysfunction is age-related, degeneration of the SA node, sinus node dysfunction can be a result of congenital disorders, arrhythmias, infiltrative disorders, and surgery. Management, again, symptomatic patients require pacemaker placement. Ayun pala. Several external causes that can affect the pacing function of the SA node. This can occur in conditions where there is abnormally increased vagal tone, such as carotid sinus hypersensitivity, vasovagal syncope, and autoimmune dysfunction. Furthermore, metabolic derangements such as hypothyroidism, hyperkalemia, hypocalcemia, hypoxia, and hypothermia can lead to depression of the pacing function of the SA node. Obstructive sleep apnea may cause bradycardia by profound hypoxia during episode of apnea. Sinus node dysfunction is a disease of older adults. It can occur in any age. The mean age of a patient with sinus node dysfunction is 68 years old. Okay, so again, the management of sinus node dysfunction includes identifying and correcting reversible causes, and treating the reversible causes, treatment of sinus node dysfunction, pacemaker insertion. In some institutions, pwede munang mag-temporary, hopefully ma-relieve, and then proceed to permanent pacemaker. So the degree of bradycardia and the impact upon perfusion determine whether or not intervention should be considered. So this is a recap for bradyarrhythmia. Conscious level is a good guide of perfusion, as is evidence of ischemic chest pain secondary to poor perfusion of the coronary arteries. Blood pressure and other indirect measures of perfusion are useful adjuncts when assessing perfusion status. The patients with evidence of ischemia in this area should have intravenous inserted and preparation should preparations available for pacing or drug intervention should be made. The initial approach to sinus bradycardia should be to increase oxygenation and ensuring an adequate preload. Simply lying the patient down and raising the legs will improve the venous return and improve the preload. If jugular venous pulse or pressure can be assessed and found to be low, a little additional IV fluid or fluid bolus should be given appropriately. If, however, the jugular vein pulse is already elevated, then increasing the preload will further be harmful, usually present to sa acute pulmonary edema. So if that's the case, you need to give the patient pressors instead rather than fluid bolus. Sinus bradycardia will often respond to atropine, as atropine effectively removes the parasympathetic brake on the SA node and to much lesser extent on the AV node. If the patient is symptomatic and oxygen and optimizing the preload with posture has already been tried, the two alternatives are to drive the inherent rate with a sympathomimetic drug or to pace the patients with an external or internal pacer arrangement. Adrenaline or your epinephrine is an excellent choice of sympathomimetic drug. Whichever drug is used, the route should be IV and ideally by a low dose infusion, gradually increasing the infusion rate until a desired response is achieved. The issue here is balancing, improving the heart rate and the coronary artery perfusion. Thus, oxygenation demand rises as heart rate force of contraction increase. Usually, the predominant effect is beneficial from the increase in coronary artery perfusion pressure. Externally applied pacemakers are becoming commonplace and can be used as an alternative. The patient should be warned that this will be uncomfortable. The pacing function is selected at initial rate of 60 beats per minute. It is not good idea to select too high rate initially, as an increase in heart rate increases the oxygen demand. So we usually set the rate if we're using a transcutaneous pacemaker at 60 beats per minute. So the current delivered should be quickly increased to a point where the capture occurs. Once perfusion has been achieved, it is appropriate to give a form of it is appropriate to give midazolam, no, or any opioid to relieve the patient's discomfort and reduce their memory of the event. In a more intensive setting, formal pacing with an internal wire can be considered, but usually the patient should be brought brought in the cath lab. Now we will proceed to your tachyarrhythmias and tracings with abnormal P wave. So kindly identify the rhythm in your screen. Luna, can you get me some water? Luna, can you get me some water? No, warm. Last 15 seconds. Is it SVT? Is it BTAC? Is it atrial fibrillation in RVR or rapid ventricular response? Or it's sinus tachycardia? Okay, so the correct answer is it's supraventricular tachycardia or SVT. So how are we going to distinguish SVT and sinus tachycardia? Number one is the heart rate. If the heart rate is more than 150 beats per minute, huwag nyo nang pansinin si sinus tach, that's usually SVT. And another morphology, because of the increased heart rate, nag-range pa ng 200 beats per minute yan, the P wave, no, nakapatong na kay T wave. So hindi mo na makita, hindi mo na ma-distinguish which is which. Is this a T wave or P wave, because the P wave is on top of your T wave. So that's your SVT. So the most common type of your SVT is called your atrioventricular node reentrant tachycardia or AV nodal reentry. In AV nodal reentry, the electrical impulse travels travels in and around the AV node. The electrical signal goes around in a circle like a race car or parang nasa rotonda, umiikot-ikot lang. The electrical signal may continue going around this pathway, causing the tachycardia to continue. The second most common form of SVT uses a second connection between the upper and lower heart chambers, a second staircase, ika nga. In this second type of tachycardia, the electrical signals goes down one staircase from the top chamber to the bottom chamber and takes the second staircase from the bottom chamber going back up to the upper chamber. So don't be confused. The most common type is the nodal reentry. So umiikot-ikot yung impulse. The second type of your SVT is meron siyang pathway na dinadaanan going to your AV node, going back to your atria. Ayan. So again, this is your AV nodal reentry. Yeah, this is now your second form of your SVT. Basically, same management din naman sila. Guys, excuse. Thank you. Cute lang lala muna po. The management of SVT usually start first with your carotid massage or Valsalva maneuver. So, apply carotid massage, but beware if the patient is 60 years old and above. Other literature hanggang 55, but in practice, it's up to 60. Do not perform carotid massage because you might throw a plaque, no? Producing, baka mag-stroke naman ang patient natin. Of course, you may also, or the doctor may give your adenosine 6 milligrams. It can also, after a minute or two, hindi correct, you may give another adenosine 12 milligrams. So 6, 12, 12. If the patient is symptomatic, okay, bumabagsak ang blood pressure, presence of chest pain, namumutla, bumabagsak ang blood pressure, you may opt or the doctor may proceed to cardioversion, which is a step 3. But before giving your cardioversion, you need to sedate the patient first. Okay, and the step 4 or last step is consider ablation or chronic suppressive therapy with beta blockers and calcium channel blockers. Okay. So if SVT is episodal or occurring on and off, it can be interpreted as your paroxysmal supraventricular tachycardia. So imagine for the first minute, we have a normal sinus rhythm. At 8:01 to 8:02, bigla tayo nag-SVT. From 8:02 to 9 a.m., we have a normal sinus rhythm. From 9:01 to 9:05, SVT. We call that paroxysmal supraventricular tachycardia, sudden change or sudden onset to SVT. So here's the approach to tachyarrhythmia recommended by the AHA. So again, look for reversible causes, monitor, attach the patient, maintain the patient on maintain patent airway rather, give oxygen, attach the patient cardiac monitor, have an IV access, and perform your 12-lead ECG. Again, same principle, check the patient's stability, if it's stable or unstable. Same questions with your bradyarrhythmia, presence of hypotension, level of consciousness, signs of shock, signs of chest discomfort, and presence of acute heart failure. If no, check the QRS complex if it's wide. If we have a narrow QRS complex, then usually we can proceed. This is an pag ganyan ang status natin, so we have a SVT lang. Okay, stable SVT. So you may proceed with your vagal maneuver. You may ask the patient to bear down, by the way, if not contraindicated. Okay, do carotid massage for 10 seconds, no? Hindi tayo buong shift magka-carotid massage, 10 seconds lang. Pag hindi gumana, huwag niyo nang ulitin. Then beta blockers. But if the patient Okay? So if the patient merong symptoms, the patient is unstable, proceed agad, okay? Cardioversion. So the doctor may opt not to give your adenosine, proceed to cardioversion. Okay? If the patient is exhibiting or presented with wide QRS complex, then we need to give adenosine if the patient is monomorphic VTAC. Okay, monomorphic VTAC. You may give adenosine or another form of antiarrhythmic, which is your beta blocker. So here's the recommended dosing of your cardioversion. You may take a screenshot. And here are some recommended dose of your medication. So adenosine, 6-12-12. We have your amiodarone, 150 milligrams over 10 minutes. Basically, between procainamide, amiodarone, and sotalol, amiodarone is the first line or the drug of choice. For cardioversion, we have narrow regular. So that's your SBT. You may start at 50 joules to 100. Narrow irregular. So that's your atrial fibrillation. If you're using a biphasic cardiac defibrillator, 200 joules. Sorry, 120 to 200. If you're using a monophasic, 200 joules. If it's wide regular, that's your ventricular tachycardia, give 100 joules. Okay. Wide and irregular, of course, you don't need to give cardioversion, but you need to give defibrillation. Okay. So this is your atrial flutter. It is a form of atrial tachycardia. The mechanism is that there's an reentrant circuit, usually around the tricuspid annulus in the right atrium. It can be asymptomatic or it can cause palpitation, shortness of breath, or hypotension. ECG will reveal regular tachycardia. By the way, sometimes hindi siya tachycardia, but it will reveal a sawtooth appearance, P wave. So parang lagare, that's the hallmark sign of your atrial flutter or atrial flare. In other countries, they pronounce atrial flutter as atrial flare. With and the general goal include control of ventricular response. So ventricular response, again, we have 1, 2, 3, 4, 5, 6, 7. We have 7 QRS complex. Multiply that by 10, we have 70 beats per minute. So how are we going to interpret this? Atrial flutter in controlled or normal ventricular response since the heart rate is 70 beats per minute. Okay? If the patient is sabihin nating exhibiting RVR, rapid ventricular response, of course, the doctor rather, may give an antiarrhythmic or beta blocker, calcium channel blocker to restore the sinus rhythm through cardioversion or ablation. So there are two types of atrial flutter. Typical atrial flutter rotates counterclockwise in direction from the reentrant circuit around the tricuspid annulus and through the cavo-tricuspid isthmus. This results in a negatively directed flutter in the inferior lead. So that's your lead 2, 3, and AVF. Negative, as you can see, yung sawtooth pababa. At times, the direction of the circuit can reverse, causing clockwise atrial flutter from the same anatomical rotation, as you can see here, clockwise. So this is your atypical atrial flutter. This will cause a positive directed flutter waves in the inferior leads in your lead 2, 3, and AVF. We have an upward sawtooth appearance A wave. Management, same. Control the ventricular response. And of course, the patient may most probably bibigyan yan ng blood thinners because your atrial flutter is a contributing factor for stroke. Okay? This is your atrial fibrillation. The hallmark presentation is irregular narrow QRS tachycardia with no discernible P wave. There is a chaotic asynchronous electrical activity in the atria. So again, wala tayong problema kay ventricles. We have a narrow QRS complex, but the problem is the atria, it's not pumping na, it's quivering, producing a coarse type appearance P wave. So atrial fibrillation is the most common arrhythmia in the United States. It is estimated that 12.1 million people in the United States will have atrial fibrillation in the year 2030. Okay. Also, because the number of AFib cases increases with age, and usually women generally live longer than men, so more women than men experience atrial fibrillation. So like what I've said, the atria does not contract but quiver. This means the atrium beat rapidly around 300 beats per minute. The most concerning about this is the formation of clot. Due to the stasis of blood, kasi nga hindi na na-empty. Okay, so the quivering, may mga blood pooling dyan. So nagkakaroon ng blood clot. So once na ma-dislodge yung blood clot, it could travel kung saan parte, can cause stroke. Okay. So there are 5 types of atrial fibrillation based on their durations. We have your new onset, we have your paroxysmal, which is self-terminating or intermittent, that lasts only for 7 days. That's your paroxysmal. We have your persistent AFib, which usually lasts within 7 days but requires treatment. We also have your long-standing, persistent atrial fibrillation, which is more than or less than a year. Permanent, persistent, permanent atrial fibrillation, usually more than a year yan. So pag nagkaroon na tayo ng permanent atrial fibrillation, hindi na siya mababalik sa sinus rhythm due to the remodeling of the atria created by the entry circuit. So atrial fibrillation can be asymptomatic or can cause palpitation, shortness of breath, irregular pulse, or even hypotension. So the management strategy for atrial fibrillation can be classified into the control rate, and rhythm control. Okay? Okay, so this is the statement of your American Heart Association on the management of atrial fibrillation during hospitalization. I won't be discussing this. Feel free to take a screenshot and you could probably read this in your own time. But I would like to highlight some key points that affects us nurses. Since it is stressed out that the management of AFib requires a multidiscipline approach, identification and recognition of triggers is vital and could impact the overall management. Another is the importance of health teaching through risk factor modification. Most probably kasi baka uuwi yan ng AFib. So lifestyle changes. So we should be an advocate of patient education. Again, management of tachyarrhythmia should start first with the following. Look for reversible causes, assessing the signs and symptoms of hemodynamically, the patient's stable or unstable. After which, identify if the rhythm, if the tachyarrhythmia is narrow or wide complex tachycardia. Okay. Now, these are the arrhythmias that are considered life-threatening. Here are your ventricular fibrillation, your ventricular tachycardia, and ventricular standstill. So basically, this is your ventricular tachycardia. So if you have a patient with VTAC, what will you do? What will you first do? Walang sumasagot? So if you have again, bigla nag-alarm ang cardiac monitor, ECG revealed, ventricular tachycardia, what will you do now? Okay, so the correct answer is letter D. Of course, you need to check for pulse. The unconscious patient should be treated as in, pag unconscious ng patient, usually tinitreat natin yan as ventricular fibrillation with a standard cardiac arrest approach. Conscious patients can be treated with either chemically or with synchronized cardioversion. The advantage of cardioversion is that there are no after effect persisting after treatment and lowering of cardiac output. Any antiarrhythmic drug use will also reduce myocardial contractility. For this reason, drug treatment of ventricular tachycardia should be reserved for patients with a reasonable initial cardiac output despite the ventricular tachycardia. In the past, lidocaine ang drug of choice, but usually or commonly, ginagawa na natin is your amiodarone. 150 mg slow IV push or usually up to 10 to 30 minutes, depende sa institution nyo. Okay? Okay. So this is a type of ventricular tachycardia or a type of polymorphic VTAC, which is your torsa de pois. Okay, so it is characterized with long QT interval. It is a rapid irregular QRS complex which appear by twisting of points in the ECG. So meron taas, baba, taas, baba. This arrhythmia may cease spontaneously or degenerate into ventricular fibrillation. It causes significant hemodynamic compromise and often lead to death. Diagnosis by that usually the treatment is with IV magnesium, kaya ka rin nagkakaroon ng twisting of points dahil bagsak ang magnesium ng patient. So treatment is you need to give magnesium. Okay, you need to shorten the QT interval and defibrillate the patient. So that's the importance of your QT. Your amiodarone can trigger prolongation of QT. So pag nakita niya ng humahaba ang QT interval ng patient, you need to refer that as soon as possible because baka pine-prevent yung mag-VTAC ang patient, mag-lead naman tayo sa torsa de pois. Okay? And again, this is your ventricular fibrillation. So same principle with your atrial fibrillation. However, kay ventricular fibrillation, si ventricles naman ang nag-quiver. Okay, so VFib is most commonly occurs due to presence of damaged fibers in ischemic heart disease, leading to reentrant of what do you call this? Of current leading to disorganized high frequency excitation or post MI. Patients with cardiomyopathies can have ventricular fibrillation due to increase in end diastolic pressure, wall tension, or the presence of abnormal channels in ventricular fibers. When the heart muscle does not get enough blood flow, it can become electrically unstable and cause dangerous heart rhythms. A heart that has been damaged by heart attack or other heart muscle damage is vulnerable to ventricular fibrillation. So again, management, of course, you need to defibrillate the patient and proceed to your CPR. This is your ventricular standstill. Don't be confused with your pulses electrical activity. Magkaiba sila. Kay ventricular standstill, as you can see, the P wave is firing. Your SA node is firing, producing a P wave. However, there's no more response from your ventricles. Their ventricles dead, pero sa SA node nagpa-fire. Usually, nakikita natin to sa mga pasyenteng arrested and then we're giving epinephrine. Okay, so meron because of your epinephrine, nagpa-fire sa SA node. However, your ventricles is not working anymore. So hindi siya asystole because asystole should be flat line. This is your ventricular standstill. Of course, management treat it as asystole. Now, I will give you an overview regarding bundle branch block and ST segment abnormalities. Bundle branch block is a block or disruption to the electrical impulse that contracts your lower heart chamber. So imagine again the impulse from your SE node going to your AB node to your bundle of His to your bundle branches. However, there's a block in the bundle branches. So what will happen? So the impulse will, dahil nga may block, will reroute. Hahanap siya ng ibang daanan, producing an extra R wave, producing an extra notch. Kaya tayo merong dapat Ay, hindi yan. Okay, pen. Okay, so there's a block in your bundle branch block. So ideally, after the impulse, magko-contract, ganyan lang siya. However, because of the presence of bundle branch block, the pathway hindi nagtuloy-tuloy. Because of the block, maghahanap ng ibang dadaanan ng kuryente, producing an extra R wave, producing an extra notch. No, and this is not life-threatening unless the patient is exhibiting signs of MI. Okay, then you may proceed to manage this as MI. But if the patient is asymptomatic, usually the patient with coronary artery disease, ay makikita talaga sa ECG, may meron tayong bundle branch block. You may identify the bundle branch block if it's complete or incomplete, depends on the extra or extra notch. If the extra notch is visible, usually like this is complete bundle branch block. If it's not visible, parang nag-slouching lang, this is incomplete bundle branch block. We can also identify bundle branch block or distinguish bundle branch block if it's right or left bundle branch block. Okay, you can identify in your screen if it's left. Okay, look at your V1 first and V6. Okay, if your V1 is W, pag ganyan ang QRS complex, and your V6 is upright, that's your left bundle branch block. If it's right naman, right bundle branch block, V1 is upright, and your V6 is also upright. Okay? So, usually, so sa mga nagda-drive, baka mas ma-appreciate nyo to. Diba ang signal light natin sa driving, if you press it up, the signal light, if you press it up, it goes right. You will go right. So same principle with your bundle branch block. If you press up, you will go right. That's right bundle branch block. If you press down, you will go left, down. So left naman ang bundle branch block, the QRS complex. Okay. So again, new onset left bundle branch block associated with chest pain are often treated as myocardial infarction. We'll now proceed to your ST segment. So moving to ST abnormalities, the most serious form of your ACS or acute coronary syndrome is ST segment elevation myocardial infarction or STEMI. Most often results from complete thrombotic conclusion or of a major epicardial coronary artery. Of course, this is life-threatening, time-sensitive emergency, early accurate diagnosis, and prompt treatment to restore coronary perfusion, usually by percutaneous coronary intervention, are critical to effective management. That's the problem in the Philippines because not all hospital are readily, ano ba sabihin nito, cath lab ready, parang ganun. As the term STEMI implies, the 12-lead ECG shows significant ST segment elevation. Unlike the ST segment depression as STT wave changes seen during unstable angina, a non-ST segment elevation MI, as you can see here, para siyang tombstone. No? So again, this is the most dangerous form of ST segment abnormalities. We can also identify the ischemic part of the heart by looking at the ST segment of all the parts of your ECG. So I won't be discussing much of this because the second speaker will further explain this. But feel free to take a screenshot for you to be able to use in your second topic. So we have your lead 2, 3, and AVF, that's your inferior wall, MI. Your V1 and V2, that's your septal wall. V3 and V4, your anterior wall. Your lead 1, AVL, V5, and phase 6, that's your lateral wall. Okay, so again, you may take a screenshot. So like what I've said, you need to look at the complete ECG tracing for you to identify which part of the heart is merong problema sa oxygenation. So looking at this tracing, what can you, saan nyo nakakita ang merong ST changes? So lead 1, lead 2, elevation. Here's the lead 3, lead 2 and lead 3, and of course your AVF. So lead 2, lead 3, and AVF, that's your inferior wall MI. Okay? So bakit natin kailangan i-identify, or sabihin natin hindi naman kailangan, what's the perks of identifying which part, which affect, ano yung apektadong parte sa ECG? Because if you're going to correlate your tracing anatomically, you will identify which part of the heart or anong vessel, anong igat yung apektado. Okay? So if you have an inferior wall MI, usually there's a left ventricular involvement, left ventricle involvement. Okay, so pwedeng LAD, diagonal, or marginal branches. So this is quite dangerous because the left side of the heart supplies the blood all over the body. And meron palang bilog, lead 2, 3, and 8. This one, so we have, meron tayong affectation sa V2, V3, V4, V5, V6. So V3, V4, that's your anterior wall. V5 and V6, that's your lateral wall. So we have your anterolateral wall MI. So ano ang nasa anterior and lateral wall ng puso? We have your left anterior descending and your left circumflex. So for those who are interested or assigned in quality improvement in your institution, I would like to encourage you guys to browse the Clinical Practice Guidelines 2021 by the American College of Cardiology and American Heart Association. It is free to download and contains numerous algorithms and recommendations in approach to chest pain and other cardiac-related topics. I'm not going to discuss this because I know that only a handful of institutions in the Philippines are practicing through protocols. But allow me to show you guys some algorithms from the said guidelines. So as you can see in the diagram, different ECG results have corresponds a different own guideline. So we have a STEMI and STEMI guidelines. There's also, you need to redo ECG once troponins revealed positive result if the initial ECG revealed an inconclusive result. Okay, there's also an algorithm for managing acute chest pain that are based on the ECG and presenting signs and symptoms. Again, lahat to, algorithm, lahat guidelines. This is an algorithm for acute chest pain for patient with medium risk with no known coronary artery disease. While this one is for managing patients with acute chest pain and stratified as medium risk with history of coronary artery disease. Like what I've said, you may download the whole practice guideline. Just key in sa Google, ACC 2021. Okay, so makikita nyo to. Yan, ito yung lalabas. So it's up to you kung anong gusto mong review, anong gusto nyong i-browse. Yan. So I would like to end my presentation by showing you factors that are considered vital in arrhythmia prevention. So as a healthcare provider, of course, we can't prevent everything, but we should be an advocate of patient education in maintaining a healthy heart and prevention of cardiac arrhythmia through the key to managing existing health conditions, following a healthy lifestyle, and avoiding substances that can trigger cardiac irregularities. So with that, we'd like to thank you everyone for listening and staying awake. So here are my resources, and I'm open now to answer some inquiries from our participants. Thank you.
Thank you very much, Mr. Agustin, for a very comprehensive sharing of expertise on arrhythmias in its management. So to all participants, should you have any questions, clarifications, reactions, or any kind, you may now queue in your questions in the chat box. And may I respectfully request Mr. Agustin to please open your audio and video for the question and answer.
Are you all practicing ba in a hospital? Sino sa inyo ang hindi currently wala sa hospital? Can I see a show of hands? Sino po ang wala sa hospital ngayon? Not working in the hospital? Wala? That's good if you're all in the hospital. Okay. So, I'm
So,
here,
Sir, I
andito
have a
lang.
question.
Go ahead, Miss Grace.
Good afternoon, sir.
Afternoon.
In most cases, po, what lead from the ECG leads po, what lead is mostly first seen? Kunwari po, nagpa-doctor's order, ECG, ngayon na. Tapos, what's the first lead po na advisable or mostly seen for quick, let's say, to recognize dysrhythmia or arrhythmia? Thank you, sir.
Oh, okay. Good question, Mama Grace, no? So, I'll rephrase your question, no? The number one, if you're using an ECG machine, okay, again, the doctor ordered stat ECG. Some ECG machine nagpe-print sabay-sabay. So isang malaking isang malaking paper, and then they're printed iba-ibang angles ng puso. However, some ECG in the Philippines they're still using the one way na printing. So the manner on how you print the tracing should be aligned with the kung ano yung mauuna. So start first with your augmented leads, then lead 1, and then your precordial leads. Lead 1, lead 2, lead 3, and then your precordial leads. But if you're using a cardiac monitor, or sabihin natin you just need a strip, for documentation purposes or to assess the rhythm of the patient, you need a long lead 2. Okay, so you don't need to attach everything, just your limb leads. Print a long lead 2. So if you're assigned in the ICU or ER, once you've attached the patient in the cardiac monitor, the default setting of a cardiac monitor is always in lead 2. Also, if you're going to pronounce a patient namatay, you need to have a long lead 2, because lead 2, the camera or the angle of the lead 2 focuses on your left ventricle, which is the apex part of the heart. So bakit kay left ventricle? Because your left ventricle pumps oxygenated blood throughout the body. I hope I was able to answer your
Thank you,
question.
sir. Yes, sir. Yes, sir. Thank
All
you
right.
so much.
Thank you. Any more questions from the group? Okay, Sir Mr. Dawatao. Sir, nakamute po kayo.
Sorry. Thank you, sir. So there's a question here, sir, that says for SVT, in the absence of adenosine in some hospitals, can amiodarone be administered?
Can amiodarone be administered? Yes. The good thing with amiodarone is it could correct atrial arrhythmias. It could also correct ventricular arrhythmias. But again, the drug of choice, I'm not saying na give amiodarone since wala naman tayo, no? The drug of choice, no, for adenosine, for SVT is adenosine. However, in the absence of adenosine, usually the second line is what do you call that? Amiodarone. 150 milligrams to IV push.
Okay, sir. Thank you. Any more questions from our participants?
Okay. Lidocaine, yes. Some hospitals still utilizes lidocaine. The problem with lidocaine is there's a lot of what do you call this? Adverse effect with the use of lidocaine. But again, it's up to the resources, no? Kung anong meron resources sa hospital natin.
Okay. So there is still one question here, sir, that says, can we consider STEMI even if this ST segment is elevated just one small box from the isoelectric point?
No. No. Usually that's to identify that there's an ST segment elevation or depression, there should be two small boxes. If it's only one small box, that's still considered essentially normal. So pag ST elevation, two small boxes above. Pag ST depression, two small boxes below. Again, the keyword is two. The minimum number of boxes is two.
Okay, sir. Thank you. There is still one question here.
Yes.
Paano daw po ibigay paano po ibigay ang IV magnesium sulfate sa torsado push po
Okay.
ba?
Actually, Ma'am Galion, it depends on the discretion of the doctor. Some give it slow IV push. Some give it naman in a drip. But I never encountered giving what do you call this? Giving magnesium sulfate na push. Any more questions? I think we're good. Anyway, if you have questions, I'll be here. I can answer your questions online.
So again, thank you very much, Mr. Agustin. At this moment, I would like to present the certificate of appreciation to our speaker. The certificate reads, Critical Care Nurses Association of the Philippines, CCNAPI awards the certificate of appreciation to John Christian M. Agustin RN for being our speaker during the online course on World Heart Day 2023, a nurse's role in acute coronary syndrome, with the topic, Arrhythmias and their management, conducted via Zoom platform on September 29, 2023, signed by Maria Isabelita Sirogado, MAN RN, CCNAPI President. So congratulations, Sir JC. We will now proceed with the next topic entitled Clinical Reasoning in Cardiac Emergency. Our next esteemed speaker is a fellow in critical care at Hong Kong Academy of Nursing. He is also a graduate of Doctor of Nursing from the Chinese University of Hong Kong and a recipient of Intensive Care Certificate from the United Kingdom Central Council for Nursing. He is currently Professor of Practice at the School of Health Sciences, Caritas Institute of Higher Education. He is also a Basic Life Support and Advanced Cardiac Life Support American Heart Association faculty. Without further ado, friends, to talk on clinical reasoning in cardiac emergencies, A warm virtual applause to Professor Chan Wing Keung David. Professor Chan, the virtual stage is yours.
Hello. Okay, thank you. Thank you, Dennis, the moderator. So can you hear me? Hello?
Yes,
Dennis?
sir.
Thank you, Dennis. Okay, hi. So thanks, Danny, for the introduction. I'm David, Professor David Chen, or you can just call me David. Thanks again to Professor Rogado and also Mr. Agustin for the invitation to allow me to share my experience on critical care. And then I received this topic, cardiac emergency and clinical reasoning. Okay, so I will spend about 1.5 to 2 hours to share what is clinical reasoning in cardiac emergency. Okay, and I must leave at around 5 because I will have another appointment after 5. Okay, so I need to do it quick. Now is 2:59, around 3. So there are 2 hours to go. And for those participants, you can drop your question in the chat room. Okay, if you have any question. Okay, I will try to answer your question. Okay. And now, okay, so this is my background. So Dennis has introduced my background. So actually, I was also a critical care nurse. I was trained in UK many years ago, and then I came back to Hong Kong. And then I spent most of my time in the IC intensive care unit of Prince of Wales Hospital in Hong Kong, which is the biggest ICU in Hong Kong. And then after that, I went to the college and then becomes an educator. I've been working in different university, and now I'm a professor of practice in this School of Health Science. And I'm also, you can see I'm also the faculty and instructor of different specialty, including intensive care, American Heart Association, the disaster and trauma care, tactical medicine, and also simulation training. I involved in all these different kind of training in Hong Kong, different part of China, and also Macau for the last 20 years. Now back to the topic today, that is cardiac emergency and also clinical reasoning. We'll just spend a few minutes to talk about what is cardiac emergency and what is clinical reasoning. And then after that, I will have some case scenario, around 3 to 4 case scenario, and then to show you, okay, how we can make use of clinical reasoning when we come across some cardiac emergency. Okay. Now I will give you some introduction about what is cardiac emergency and also what is clinical reasoning. Okay, so I'm sure the participants here are all working in the ICU, okay, intensive care unit or critical care unit. I'm sure we often have experiences in managing some patients who have developed cardiac emergency. Okay, so early recognition and quick response are essential, okay, to achieve optimal patient outcome. Common cardiac emergency, I'm sure you know there's a long list of these common cardiac emergency, which include acute myocardial infarction, cardiogenic shock, life-threatening arrhythmia. Okay, yeah, I think John has just given a lecture on this life-threatening arrhythmia. Acute heart failure, cardiac tamponade, aortic dissection, acute myocarditis, cardiac arrest, etc., etc. Okay, and as I mentioned, it is essential for critical care nurse to have the ability to early recognize and identify patient's problem, number one, and also to give appropriate intervention to manage the patient and the patient's problem. And to achieve this, we need to develop and make use of clinical reasoning, okay, to help us to make a good judgment. Then what is clinical reasoning? Clinical reasoning, people said that it is a process thinking about something in a logical way, in order to help us to make a judgment, to make think something in a logical way, and then to help us to make some judgment. Of course, clinical reasoning is talk about the clinical area. Okay, so it refers to the application of critical thinking. Critical thinking is to make judgment about what we observe, what we come across. Okay, to the clinical situation. Okay, and it is also a process of making a clinical decision or judgment logically and rationally by healthcare professionals to identify patient problem and to determine an appropriate intervention. Okay, and also it is a complex cognitive process that is essential to enhance the healthcare professionals to number one, assess the patient's problem. Number two, to do a care plan and to a care plan about this patient, to implement the step, and also to evaluate the care that we have given to these patients. And most importantly is you can see clinical reasoning is a process by which nurses observe the patient status, process the information, understand the patient problem, plan and implement intervention, and evaluation outcome. And the most important is have a good reflection, okay, and learning during the whole process. And this is important to help us to sustain some improvement in future, okay, some improvement in our performance in future. Then why is clinical reasoning important here in healthcare? I'll say, okay, this author talk about this. They think that nurses with effective clinical reasoning skill can have a positive impact on patient outcome. And this is important because we can make good judgment, and then we can identify the patient problem more appropriately, and also we can give an appropriate treatment to the patient to enhance a better patient outcome. And conversely, those with poor clinical reasoning skill often fail to detect impending patient deterioration and resulting in a failure to rescue. Okay, so you can see the difference, why it is so important to have clinical reasoning in a healthcare setting. Now here let us go through a clinical reasoning cycle. This is by Smith. Okay, and then it talks about 8 phases of clinical reasoning, including consider patient situation, like or chief complaint. So when you go to the ward or go to your ICU, your patient suddenly might have developed acute airway obstruction, or a patient might have developed some breathing difficulty, or patients have some kind of shock or hypotension, or suddenly the patient's conscious level drop. Okay, have some kind of sudden changes in patient situation. And then number 2, we need to collect the patient data. Okay, and then after that, we need to process and analyze different patient data and identify the patient problem. And then afterward, and then we need to set a goal, take action, evaluation, and also most importantly, do a reflection for sustaining better performance in future. Okay, so this is a clinical reasoning cycle. So let us go through it one by one. Number 1 is consider patient's situation. Like, okay, so we should be able to notice any change in patient's condition. Okay, so when you go to ICU, and then we check our patient. So if the patient has some kind of changes in patient condition, we should be able to notice that, notify that. Okay, for example, just as what I've mentioned, patient might have developed a sudden acute airway obstruction, like gurgling sound in the mouth, or breathing difficulty, shortness of breath, or cyanosis, hypotension or shock, okay, and also decrease in conscious level. Okay, and then once we have identified this, and then we need to immediately provide some what we call primary survey, and then carry out some immediate action to stabilize the patients first. What we call the ABCD, airway, breathing, circulation, and disability. That is the neural, the neural part. Okay. And then we need to start after we give some we have given some initial treatment to stabilize the patient's problem, and then we need to collect patient data, including patient history. So a brief and concise history. I'm sure you all know this OPQST and also the sample. Okay. Okay, use a very concise and quick method to collect patients' history, and then vital sign. Okay, the standard blood pressure, pulse, respiration, temperature, SpO2, etc. And then we need to do a focused physical examination. Okay, based on the patient's chief complaint. The patient complaining of shortness of breath or chest pain, and then we need to do a heart-lung examination. Okay, the respiratory assessment and also the cardiovascular assessment, because the lung and the heart affect each other. So once we need to do health assessment, we need to do both together. No matter patient have chest pain or also have shortness of breath. Okay, because a patient with chest pain might not only be due to the heart problem, QMI. Okay, chest pain can also due to lung problem like pleurisy. Okay, the inflammation of the pleura. And also, if patient has some shortness of breath, it might not be only due to the respiratory problem like asthma, chest, COPD, or infection. It might also due to heart problem like heart failure. Okay, so usually we do the heart and lung examination together. Okay, and yes, and then we need to, if the patient develops some decrease in conscious level or a headache, etc., of course, we need to perform some neuro examination. And the patient have some kind of abdominal pain, of course, we will do the abdominal exam first. Okay. And then, okay, after doing the focused physical examination, and then we need to develop a number of differential diagnosis. For example, patient has chest pain. But there are thousands of causes that can result in chest pain. So we need to think about, okay, pick up some important one. Okay, what do we think that can be the reason of the patient's chest pain? We pick up a number of 7, 8, or 10. Okay, a number of differential diagnoses that can be related to the patient's chest pain. Okay. And then we need to start process and analyze patient data. Okay, we need to check the patient's laboratory data result, ECG tracing, X-ray, film report, and some other test results as well. Okay, and then these are useful and to help us to reject those unlikely diagnosis. And then we hope that it can narrow down and then to refine the final diagnosis. Okay, that is more appropriate to the patient's problem. Okay, so okay, so after screening all the result, and then we are able to reject some unlikely diagnosis like this. Okay, cross, and then narrow down to disease that is more likely that is related to the patient's problem. Okay. And then after that, after we have identified or refined the patient's diagnosis or problem, and then we can set goals. Of course, in this kind of situation, we focus on the short-term goal first because patient has sudden changes in patient's condition. Okay, so we need to stabilize the patients first. Focus on the short-term goal, like the ET tube insertion to maintain patient's airway, or put patient on ventilator to maintain effective oxygenation and ventilation, and or maybe we give foot challenge and inotrops to maintain adequate organ perfusion, etc., etc. Okay, all these are short-term goal. Okay, for long-term goal, so after stabilizing a patient, we might develop the long-term goal later on. Okay, but that is not very important at this moment. Okay, like wean off the patient from ventilator or start the rehab program. That can be postponed a bit later. We focus on the short-term goal first. If we come across some patient with clinical emergency, sort out the patient's problem first. Sort out the problem that can kill the patient first. Okay. And then we need to take out do some intervention, including the medical the prescribed medical treatment and also the nursing and nursing intervention. And then after that, we need to do evaluation to see whether the patient has improved or not. Okay, and then the lastly, and this is also important, is the reflection. Usually in our training, we use this Gibbs reflective cycle. I'm sure you also know this cycle. Okay, and then we need to do some kind of debriefing to our learners, and then to help them know what they have learned in from this event or experience. Okay, did they feel good and bad? And then what does the situation reflect? Okay, and also if it happened again, what would they do? Okay, so this can hopefully it can help to sustain their future performance. Okay, and then now we talk about this clinical reason. Actually, there are two approaches. One is for the non-emergency approach, and then one is for the emergency approach. For the left one, on the left side, that is for the non-emergency approach for stable. This is the design for stable patient. On the right side, that is the emergency approach. That is designed for the unstable patient. Okay, so let's check the left side first. For left side is for those stable patient. Okay, so patient does not have any significant problem related to airway, breathing, circulation, and disability. That is the neural function. Okay, so we'll analyze the patient shift campaign, take the history, collect the patient's vital sign, do the physical exam, and after all these have finished, and then we can start giving a differential diagnosis. And after that, we can analyze different types of laboratory data result, laboratory, ECG, X-ray, and other laboratory results. And then we now here at this moment we can reject certain unlikely diagnoses and then narrow down to what we find diagnosis. Okay, and then after that, doing intervention and duration and reflection. This is only an non-emergency approach for stable patient. Okay, but here for this now we're talking about cardiac emergency. So these patients are unstable patient. So we use the other one. The other one, that is the emergency approach. Okay. So after this, I will have 3 to 4 case scenario talking about this emergency approach for unstable patient who have developed cardiac emergency. Okay, so you can see that some difference for this emergency approach. Once we detect patient have a chief complaint related to A, B, C, D, airway problem, breathing problem, circulation problem, and D, that is neural problem, disability. Okay, and then we need to do a quick primary survey and immediate treatment first to stabilize the patient first before moving on. Okay, here we will think about the differential diagnosis first. Okay, so in our mind, and then we will think about for example, patient coming with chest pain. We will think about, okay, what could cause patient's chest pain? We pick up a number of diagnoses. That is differential diagnosis. And then after that, okay, we will do the history, vital sign, physical exam, and read up all the laboratory results, and then do the interpretation. Okay, and then we will do the and then we will start rejecting the unlikely diagnosis. Okay, and then narrow down to we find our final diagnosis. And then after that, we give intervention and duration and reflection. Okay, so in here we use an emergency approach. Okay. Using clinical reasoning in cardiac emergency. So the following, we have 4 case scenarios to demonstrate how we use clinical reasoning in clinical emergency. Okay, so when I'm talking about this case scenario, okay, so all the participants here, you can make use of this chat room. Okay, you write it down. Okay, you can ask question or you can answer my question. Okay, so I invite you to participate in my this presentation. Okay, so case 1. So are you ready? Okay, so case 1. Peter, male, 35. Complaints of chest pain with shortness of breath is admitted to your hospital. Now you are an advanced practice nurse, and now you come to assess this patient. Okay, because this problem involve A, B, C, D. Okay, this is the chest pain and with shortness of breath. This can affect patient's breathing and also circulation aspect. So this is an emergency situation. Then we need to start with do a primary survey first to identify problem and then stabilize the patient's problem first before moving on. Okay, airway, he complains of chest discomfort. Breathing, look, okay, he's cyanotic. He use accessory muscle. Okay, respiratory rate 26, and air entry on both sides equal. And when we feel palpate the patient, there's no subcutaneous emphysema. For circulation, there's no always bleeding or external bleeding, and the radial pulse is rapid and feeble. Skin temperature cold and wet, and capillary refill 3 seconds. Disability, AVPU patient is alert. Pupil is equal and relative to light, 3 mm both sides. Okay, what problem have you identified here? Okay, participants, can you keep your answer here in your chat room? A, B, C, D, any problem you have identified? Please participate. Okay, hello. Wait, okay. All the participants, can you participate in my presentation? I say A, B, C, D, what problem have you identified? You can put your answer in the chat room. Anyone? No? B and C, okay, very good, thanks. Thanks, Hazel, okay, B and C, B, C, okay. So now, yeah, okay. So patient's breathing has problem and also circulation has problem, okay. I think not a lot of hospital keep a milk, all because it is compared to it, okay. You are talking about the previous question with John, okay, okay. Wait, we talk about this topic first. Thank you. So here a patient can talk. He complain of chest pain. That is, he can talk. It means that the airway is patent. Airway no problem. Okay, for breathing, patient is cyanotic, use of accessory muscle, respiratory rate 26. Okay, and then I think that's problem. So we need to give an oxygen mask to the patient here. And for circulation, obviously the patient has developed what hypotension or shock. Okay, a rapid and feeble radial pulse. Usually, clinically, we make use of the pulse to estimate the blood pressure. Okay, especially in emergency or hospital setting, or even in critical care. Okay, if we don't have too much time to do the blood pressure, and then we check the pulse. If there is a presence of radial pulse, it means that the patient at least has a systolic blood pressure up to 80 to 90. Okay, and if the radial pulse is absent or it is very weak and rapid, and then it also means that the patient's systolic blood pressure might be below 80. Okay. Okay, this is for radial pulse. For femoral pulse, that is systolic blood pressure. If present, it is 70. And then for carotid pulse, if it is present, at least the systolic blood pressure is 60. Okay, 80, 70, 60. We use a lot of this kind of approach during the emergency situation, in emergency room, and also in the hospital setting. Obviously, this patient has developed shock, and then we can consider giving IV fluid to this patient. For neural aspect, okay, there's no problem. Okay, patient is alert, and the pupil is equal in reactive 3 mm both sides. There is no problem. So no treatment here. Okay, also normally I should ask you to give me a number of differential diagnoses here, but it might spend a lot of time. So I just pick up some as an example only. Okay, of course you can think of some diagnose that does not belong to here. Okay, so here I suppose a patient might be patient's chest pain might be due to one of these items. Okay, like aortic dissection, cardiac tamponade, acute myocardial infarction, pericarditis, myocarditis, pneumothorax, pruritus, pulmonary embolism, cholecystitis, and anxiety disorder. All these problems can induce patient's chest pain. But okay, but we need to later on we need to identify evidence to reject it. So reject the unlikely diagnosis, and then hopefully that we can narrow down to diagnose that is more appropriate for this patient. Okay, so we think about this first. Okay, we'll come back to this later on. Okay, and then we start to take history. We use the OPQFT and sampler to check the patient's history. Onset. Okay, this patient's chest pain and shortness of breath developed at 12 noon today. And now assume now is 3 p.m. Okay, again, this is 3:23. Okay, and then for provocation and palliation, he feel more pain when walking or walking upstairs or just walking, and he has less pain when rest. And the quality is that it seems there's some tight pressure on the chest, and the region and radiation is the pain is in the retrosternal area, and also it radiates to the jaw and the left shoulder. Okay, so it seems that it is rather obvious. Okay, and then the severity is 7 out of 10, and the time is 3 hours. Since 12 noon up till now, continuously 3 hours, there is still chest pain. For the sampler, patients have the chief symptom is chest pain. Patient might have the different symptom at the same time, like chest pain, shortness of breath, dizziness, fever. Okay, but I ask which one is most important, and that needs medical treatment first. Okay, chest pain. Allergy, there's no food allergy or drug allergy. Medication, the patient said he really could not remember the drug name. The doctor just told me that it is some kind of anti-lipid drug. Okay, and then for pastel, also the doctor told him that he has high lipid level in the blood. Okay, last meal, breakfast at 7 a.m. this morning, and the event, no idea. He does not know why the pain suddenly comes sudden. Okay, risk factor, that is, patient has high blood lipid level, but there's no hypertension, no diabetic, and no recent travel history. Okay, so here, what clues can you identify here? Okay, anyone? Okay, what clues can you identify here that that is related to patient's chest pain? Hello? Hello, other participant, can you participate? Yeah. What clues here can you identify that is related to patient's chest pain? Anyone? More pain when walking, tight pressure on the chest. Okay, this is okay. So this characteristic is quite similar to what kind of disease or what kinds of problem? Okay, what kind of problem? Okay, yes, maybe maybe a QMI, or maybe other than a QMI, there may be other problem. Okay, so you think about a QMI first. Okay, now carry on. Okay, very good. Thanks for the participation. Okay, so we can notice that some significant point here: tight pressure on the chest, and also the pain is in the retrosternal area, and then it can radiate to the jaw and also left shoulder. And also patient is on anti-lipid drug. He has a high lipid level. Okay, all these can be related to patient's chest pain. Okay. So sorry, there's some problem. Okay, now we do the vital sign for this patient. Vital sign for this patient, and then blood pressure 85, 50, pulse 120, respiratory rate 26, SpO2 92, and also temperature. And patient shows some disease. So what problem to identify? Okay, so this is simple. I just tell you. Okay, patient has hypotension. And then what we can do immediately is to increase the IV fluid rate. Patient has rapid pulse rate. That is the compensation for his hypotension. Okay, and and then also the rapid fast respiratory rate, and also SpO2 drop to 92. And then in that case, we need to increase the oxygen concentration. Temperature okay, the patient is awake, but patient has some dizziness, which might be due to the effect of hypotension, isn't it? And then patients has some, and then we because patient's chief complaint is chest problem, okay, the chest pain, okay, and also the shortness of breath, and then we decided to, or you might decided to perform heart lung examination first, okay, the respiratory system and also cardiovascular system, okay, okay. And then, okay, the finding is here. Now there's a bilateral chest and diffuse crepitation for the chest. And also for the cardiovascular system, there's engorged neck vein. And then there's a gallop rhythm with sound free. And patient is conscious, alert, GCS E4, V5, M6, pupil equal to life and reactive, okay, 3 mm. And also patient has some fake abdominal discomfort, okay. So what can you think of when patient has this kind of physical examination finding? Patient have bilateral chest with diffuse crep, what is it? Okay, shock, cardiogenic shock, okay, patient has shock, okay, cardiogenic shock. Okay, so why there is diffuse crepitation on bilateral chest? What is it? A diffuse crepitation on bilateral chest. Anyone? You mentioned about cardiogenic shock, okay? Means that the heart's pumping force is very weak. Then what happened next? Because the heart cannot pump the blood properly, and then some blood or fluid will retain in the lung, and then what can happen? What can happen? Anyone? Anyone? The lung will become congested, and then that will cause pulmonary congestion or pulmonary edema. And also patients has an engorged neck vein, and also there is a gallop rhythm with sound free. What does an engorged neck vein reflect? Engorged neck vein. Language left ventricular failure, maybe. Okay, let's move on first. What does engorged neck vein reflect? What does it? Engorged neck vein, that is what? High CVP. Engorged neck vein means high CVP. So that is hypervolemia or heart failure. All right, okay. The heart is not able to empty the heart properly. Okay, so that is heart failure. And then what is gallop rhythm with sound free? What is gallop rhythm with sound free? You tell me. Gallop rhythm. That is gallop rhythm. Okay. When gallop rhythm will occur? Tell me. When will the gallop rhythm occur? Gallop. No one try. That is heart failure. A sign of heart failure, gallop rhythm with sound free. Sound free is actually an abnormal sound produced by the excessive compensation of the ventricle. When there is heart failure, the heart is trying to compensate, and then the ventricle will contract forcefully to do compensation, and then it will produce some abnormal sound free. Okay, and also patient is conscious and patient show abdominal. Okay. So we have mentioned about this. Okay, so patients have bilateral chest with diffuse crepitation, or might be the lung is very congested, and then the patient has a engorged neck vein, and also gallop rhythm with sound free. Okay, patient might have a heart failure. Okay, and for the abdomen observed at this moment, the patient develops some fake abdominal discomfort. Okay, we don't know what happened at this moment. Just observe. Okay. And patients come again, some laboratory result, cardiac biomarker, CHOP I 0.15, and then there's a blood gas result. Okay, any abnormality, can you tell me here? Biomarker, Do you remember the normal range of CHOP I? Normal range of CHOP I. What is the normal range? Anyone? Hello? What is the normal range of CHOP I or CHOP T? Below what level? Normal one. Normal one. Yes, around the point. No. Normal is below 0.03. Normal is below 0.03. Okay, but it is significant only when it is above 0.1. Only when it is above 0.1. Okay, and also the blood gas. Who can tell me what is the acid-base problem here? Blood gas. Anyone? What is the acid-base disorder here? Anyone? So obviously the CHOP I is very high. Okay, so because normal is 0.03, and then when it is about 0.1, it is significant. Okay, so it is significant. What does it mean? Okay, what does high CHOP I level imply? Uncompensated respiratory acidosis. Okay, uncompensated respiratory acidosis. Not fully correct. Not fully correct, because both high CO2 and also low bicarbonate can also cause acidosis. This is a mixed type acidosis. This is a mixed type acidosis. Okay, because the patient's blood pressure is low, it can cause metabolic acidosis. Okay, when patient's ventilation is not effective and the CO2 is high, it can cause respiratory acidosis. So actually, there are two causes here. This is mixed type acidosis. Also, the oxygenation is not good. It is patient is on 0.3, that is 30% oxygen, but the PaO2 is 8 kilopascal or 60 mmHg, and saturation is 92. Okay. Okay, so actually, normally, I hope you can work out the PF ratio for me. And now, okay, I'll show you. Okay, you know what's this is the PA ratio. This is partial PaO2 over FiO2. Okay, what is the tell me what is the normal range of PF ratio? Normal range of PF ratio. Can you tell me? Now we normal subject. What is our PF ratio? Now, for example, now I take blood from all of you here. I assume all of you are healthy. Okay, and we are now breathing room air. Okay, room air, that is 0.21. Okay, 0.21. Okay, and the blood result should be your PaO2 should be 100 mmHg, and then we use 100 mmHg to divided by 0.21. That is the room air. Okay, the result is 476. So actually, our normal value should be 470 something. That is the PF ratio. I'm sure you are ICU nurse. You know the Berlin definition of the ARDS. Remember Berlin definition of ARDS? They use the PF ratio to define what is the mild form of ARDS, moderate ARDS, and also severe ARDS. Okay. Okay, so 200 is very bad. Actually, below 300 is bad. Okay, still remember below 300 is the mild ARDS. Below 200 is moderate ARDS, and below 100 is severe ARDS. So the patient here is 200. Actually, it is not very good. It is not very good. At least it is about 300. Okay. So here we can see the cardiac marker is very high. Normal range is below 0.03, and then when it is significant when it is above 0.1. Now it is 0.15. Okay, it may reflect some kind of myocardial injury. Okay, so some of you mentioned earlier that the patient might have developed acute MI. Okay, so this might be possible. This might be possible. I'll move on. Okay, who can tell me? Okay, what kind of acute MI does has this patient developed? Anyone? STEMI. I know it is a STEMI, but which part of the heart there is ST elevation? Which part of the heart? Tell me. Inferior, brachial, I cannot pronounce, sorry. Brachially, okay, sorry. Inferior, just, okay, Jonah, inferior only? More than that? Any more? All of you just notice inferior? More than inferior? Can you tell me? Any other one? There are about 50 participants here in this room, I can see. Okay, so other participants can also involve anterolateral, not anterolateral, anterolateral, inferior lateral, yes, inferior lateral. Okay, septal. Septal is part of anterior. Okay, same, inferior, anterior. Any more? No, inferior, not, there's no anterior MI. No anterior MI. Okay, now I'll give you the answer. No more answer. 3. Inferior MI, okay, lead 2, lead 3, AVF. Okay, and also, okay, lateral MI, V5, V6. Okay, normally, the whole group of lateral zone is lead 1, AVL, V5, and V6. But according to the principle of ECG, any two consecutive lead in each group show ST elevation is still regarded as MI, acute MI. So there's inferior MI. You can see ST elevation in lead 2, lead 3, AVF. This is inferior MI. And then there's ST elevation in V5 and V6. That is lateral MI. And also there is posterior MI. How to read posterior MI? So this is posterior. Okay, I need to skip some. Okay, so you can see the picture I draw here. Okay, so this is inferior. So this part has elevation, ST elevation. It shows that this inferior wall of the heart has acute myocardial infarction. Lateral, that is this shown. Okay, and also this one is this posterior wall of left ventricle. Normally, if we have 15 lead ECG or 18 lead ECG, we can actually stick the leads on the patient's at the back, the left side of the back. Okay, and then we can directly measure the V7, V7, V8, and then also V9, and then we can tell there is a QMI if there is a ST elevation or QN or Q wave over this lead. Okay, how to know how should we interpret there is a posterior MI or not? Okay, like this. Okay, I'm sure you know about mirror image, mirror effect. Okay, as I mentioned earlier, we can actually directly stick the list on the patient's back. Okay, the left side of the back, and then to detect whether there is a posterior MI. Posterior, that is the posterior wall of left ventricle. Okay, but if we don't use this approach, we can use the conventional approach, that is to detect the mirror effect of the posterior MI. So if there is a QMI over this posterior zone, it will project its effect on the opposite wall, that is project on V1 as an inverted ECG image. Okay, this is what we call the mirror effect. Okay, you look at this picture. Okay, I cut this picture and then turn it to the other side. So can you see it? This is mirror effect. Can you see it? Tell me. Can you see it? Okay. So V1 and V2, when there is a presence of this R and ST depression, and also you can see in V2 there is an uprighted T wave. It means that when we turn it to the other side, we can see, okay, there is a Q wave, there is ST elevation, and there is inverted T. Okay, so that is the way how we interpret posterior MI. Okay, cut this part, or you turn the paper over the sun when there is some light, strong light or sunlight, and then you can see turn the paper to the other side, and then you can read this part. This is posterior MI. Okay, so actually this patient has developed 3 parts of acute myocardial infarction. Okay, on this side. Okay, and then okay, and then patients X-ray come back. What is this? Can you tell me? Can some of you tell me what is this X-ray? Anyone? Anyone? What is this X-ray? What does it show? A bilateral chest with haziness or local infiltration. What does this show? Actually, when we did the physical exam, patient show what? Congested lung. So what is this? Anyone? No one? This is APO. This is acute pulmonary edema. X-ray show bilateral back spring. Back spring, it means it just simply means very symmetrical on both sides, because this is due to the overall change of the intrathoracic pressure. Or okay, so both sides show this bilateral haziness and or local infiltration. Okay. If there is only one side, that is not pulmonary edema. Pulmonary edema must be two sides, must be bilateral. Okay. And also, I don't know whether you have heard this or not. That is the curly B line. Okay. So, any one of you here, you heard about curly B line here? Curly B line here, you can see I use a red bracket to show this area. You can see many white line here. That is the edematous septum of the or the lymph node. Okay, so in case of acute pulmonary edema, the lung is so edematous that all the alveolar septum will be filled up with fluid, and then you show up this you can see this horizontal white lines here, small white lines here. Okay, so this is curly B line. This is typical for acute pulmonary edema. Okay, and also if we look at the POCUS is the point of care ultrasonography. That is the bedside echogram. Okay, it shows that the ejection fraction is 30. Okay, who can tell me the normal value of ejection fraction? Who can tell me the normal value of ejection fraction? Anyone? Hello? Normal value of ejection fraction. 50 or higher. Yes, 50 is normal. 50, very good, very good. 50 is normal, but 40 is marginal. Sometimes we accept 40. Okay. Yeah. So 50 is normal. 40 is marginal. Below 40 is low. Okay. Okay. So so this is so we can make use of the POCUS to assess the ejection fraction. Okay, by just measuring the diameter of the ventricle during systolic phase and also diastolic phase, and then we make use of formula, and then we can work it out. Okay, this is not difficult. Okay, so the patient, so it means the patient's ejection fraction is low. It means that the stroke volume is also low. The cardiac output will also be low. Okay. And then, okay, so after all these examination and data analysis, and then we are able to reject some unlikely diagnosis. Okay, number one, aortic dissection, no, because patients why the right radial pulse and left radial pulse, there's no difference. Okay, and the POCUS also negative. It does not show any aortic dissection. Cardiac tamponade also, the POCUS is negative. The ultrasound result did not show any compression of right atrium. Okay, QMI is likely because there's a high troponin eye level. The ECG show STEMI, so free area, the inferior wall, the lateral wall, and also the posterior wall. And also there is a low ejection fraction. And pericarditis, no, the physical exam does not show any pericardial friction rub, no. And also ECG show no generalized ST depression. Myocarditis, no. Again, the history did not mention any viral infection, because viral infection commonly will induce viral myocarditis. Okay, and ECG does not compatible with myocarditis. Again, for both pericarditis and myocarditis. Okay, can any one of you tell me what will be the ECG finding when there is pericarditis or the myocarditis? Anyone? No? Okay. So there will be, because for pericarditis or myocarditis, the whole heart, okay, is inflamed or infected. Okay, Okay, inflamed. So it's just like there is myocardial injury all over different part of the heart. So there will be generalized ST elevation. All the lead will show ST elevation. So this is a pericarditis, and also it also applies to myocarditis. Okay, of course the pattern of ST elevation is a bit different from the acute MI because it is concave upward, if you know. Okay. For the typical acute myocardial infarction, the ST depression is convex upward. Okay, and also for acute MI, the lead involved is only localized. So, for example, if patient has only inferior MI, so only lead 2, lead 3, and lead AVF will show ST elevation. The other lead will not show. Okay, but for pericarditis and myocarditis, all the lead will show ST depression. Okay. And also for pneumothorax, okay, it's an X-ray chest negative, negative finding, no pneumothorax, and also ultrasound is also negative, because if you know how to use the ultrasound, it can show some sliding pleura. If there is not normal, it's here it shows sliding pleura, but if there is a pneumothorax, there is no sliding pleura effect. Okay, pleurisy, the inflammation of the pleura. Okay, physical exam show no sharp pain during inhalation, and X-ray show no pleural effusion. So that is not pleurisy. Pulmonary embolism. Do any one of you know about pulmonary embolism? It's the ECG pattern. Okay. Do you know what is the S1Q-VTP syndrome? And also right bundle branch fault. Okay, this is pulmonary embolism. Okay, we'll talk about this later if we have chance to talk about it. Cholecystitis, Murphy sign negative, so that so it is not the chest discomfort is not due to the cholecystitis. And also anxiety, patient has no history of anxiety, and patient is very calm at this moment. So if the chest pain might not be due to the anxiety. Okay, so after all this rejection, we only leave the acute myocardial infarction. Okay, so actually patient has developed acute MI with acute pulmonary edema and also cardiogenic shock. Okay, some of you also mentioned earlier this patient is is having cardiogenic shock. Okay. Okay, some more information about acute MI. All these are acute MI with typical ECG presentation. Okay, so we are quite familiar with all these acute anterior MI, natural MI, inferior MI, posterior MI, and also right ventricle MI, isn't it? I'm sure you all know about it. Okay, you know how to identify the different lead to make a conclusion that patient has certain kind of typical MI. I'm not sure if you also learn about some acute MI with atypical ECG presentation. Have you known? Okay, do you know about all this? Like a left main coronary artery occlusion, diagonal one left anterior descending artery occlusion, Weldon syndrome, and also the Winter syndrome. Okay, all these people said all these patients might have also developed acute MI. But they will show some atypical ECG presentation, okay, which does not like our typical ECG presentation for the ECG for the acute MI that we know. Okay, we can go through that one by one. For example, there's an acute MI over the major. This is what we call the left main coronary artery stenosis. Okay, so when the patient have left main coronary artery stenosis, the major area of left ventricle will also be infarcted. And the ECG tip is very atypical. Okay, so you can see there is ST elevation on the AVR, and there is the ST depression over the inferior lead 2, lead 3 AVF, and also there is the ST depression over V3, V4, V5, V6. Okay, so this is what people call the left main coronary artery stenosis. This will cause also the infarction of the major area of left ventricle. Okay, I think I'm not sure if you heard about this before. This is number one. Number two, this is what we call the first diagonal branch of left anterior descending occlusion. This is also one type of atypical MI. Okay, so the affected area is the lateral wall of left ventricle. Okay, ECG presentation is, you can see ST elevation on AVL, and then also there's ST depression over lead 3 and also AVF. Okay, of course, patient's cardiac marker will be positive. Okay, the CHOP-I, CHOP-T will also be elevated. Okay, and this is another type of atypical MI or MI with atypical ECG presentation. Number 3, this is called Wellens syndrome. Okay, this is Wellens type A, and this is type A, and that is type B. Okay. Wellens discovered that when the patient has some kind of anterior wall of left ventricle infarction, okay, there are two types of presentation. Number 1 is biphasic T wave over V1 to V4. Okay, you can see for over V1 to V4, the T wave is biphasic. Okay, up and down. That is what we call the biphasic biphasic. Okay, the B type is also over T wave inversion. T-wave inversion over the V1 to V4, but this time it is purely a T-wave inversion. Okay, okay. So according to Wellens, patient has also developed the anterior wall of left ventricular infarction. Okay, if patient show this kind of ECG pattern, and also the last one is the winter syndrome. According to this author, the winter, and then if a patient has this anterior wall of left, but this condition is very rare. Only 2% of people will have this kind of atypical ECG presentation when they have acute MI. Okay, patient will have AVR with ST elevation over AVR, and also there's upslope ST depression and tau T in V1 to V4. You can see. Okay, what is upsloping ST depression? You can see the ST segment move down first and then go upslope. Okay, move down first and then go upslope, and then together there is a tau T over V1 to V4. This is what the people call with the winter syndrome. Okay, so all these QMI with atypical ECG feature, it is quite different from what we what we have already known. Those anterior MI, posterior MI, inferior MI. Okay, so these are some supplementary information. So when you come across patient with chest pain, cardiac marker so they might show some kind of this atypical ECG picture. Patient has also developed acute MI, but the patient does not have the typical ECG that we normally see. Okay. I hope you okay. This is useful to you. And suggest intervention. Patient has ST elevation MI. Of course, we can suggest. We discuss with the doctor and then suggest some treatment for the patient, including the PCI or the thrombolytic or fibrinolytic. For the cardiogenic APO, we give oxygen to the patient, or we use the non-invasive ventilator. Okay. Of course, we can also give the GTN and diuretic. And for cardiogenic shock, we can use inotrope, or we might need to use intra-aortic balloon pump. Okay, if the inotrope does not work properly. Okay, and all this I'm sure you know about this. The AHA, the guideline 2020 about this ACS management. Okay, so I'm sure you all know all this already. So this is a pre-hospital management. When the EMT or EMS arrive the patient's home, patient complain of chest pain, and then they suspect suspicion of acute MI. Okay, and then I'm sure you know all this about this. Okay, we start with we use MONA. Okay, morphine, oxygen, GTN, and aspirin. Okay, we give this to the patient. Okay, and then and then the EMT can also notify the hospital about this patient with suspicions of acute MI. Okay, and also if the acute MI is confirmed, he also used the fibrinolytic checklist to check the patients whether he's suitable for doing the PCI. Okay. This is also this AHA guideline. Remember, this is the right side, the STEMI, and then middle the non-STEMI, and also the left side the non-diagnostic. Okay, for STEMI, we do the reperfusion therapy, that is use either PCI or the fibrinolytic drug. Okay, and for the non-STEMI, okay, that is we use some kind of adjunctive therapy, or what we call the anti-ischemic therapy. This is to give patient heparin, GTN, anti-platelet drug, including the clopidogrel or the GP 2B3A. 2B3A should be 2B3A. Okay, and also the beta blocker, etc. And for patient with non-diagnostic, and then we just keep observe, and then we check the test a few hours later. Okay, so this is simple. Okay, so this is case one. Okay. So so if do you have any problem with case one? You can ask. If no, I will move to case two because I have 4 cases today. I hope to finish all cases before 4:50 because I will have an appointment at 5 p.m. Okay. Okay. So any question you can ask, or you can put in the chat room about case one. Case one is a patient with acute MI and also complicated with acute pulmonary edema and also cardiogenic shock. Okay. So I assume you have no question at this moment. Again, I will move on, and then you can also ask later on. Okay. So case two. Case two. Okay, ready? Paul, male 45, found unresponsive and cardiac arrest at home by family, and then the family no CPR, and then they started CPR at 7 a.m. this morning, and the EMT arrived, and the CPR and defibrillation for his VF, ventricular fibrillation, were done at scene, and he assumed ROS, return of spontaneous circulation. The EMT sent him to your hospital. Okay, now you and your crash call team come to assess this patient. Okay. Now you are the crash call team. You need to answer this question. Okay. Again, because this is an emergency situation, we need to do the primary survey first to stabilize the patient first, give treatment, and then before we move on. Okay. Airway, he's intubated, put on a portable ventilator on volume control mode, tidal volume 400 ml, our respiratory rate 12, FiO 2.5, and then breathing, synoptic. The patient is still synoptic, SpO2 92, air entry both side equal, and then no subcutaneous emphysema on palpation. And for circulation, no bleeding, no obvious external bleeding, and radial pulse rapid and feeble. Blood pressure 85/50, skin temperature cold and wet, capillary refill 3 seconds, and neural, that is GCS unresponsive. E1, VT, M1, and also pupil 6 mm, both sides equal but sluggish. Okay, what problems have you identified? Tell me. Any problem? You just put down A, B, C, or D. Okay. Any problem? Hello? C and D. Okay. Just C and D. No problem about B. There is synoptic. Yes, B. Okay, there is a hypoxemia, synoptic. Okay, and also airway, but patient has ET tube additional. Patient has been intubated, no airway problem at this moment. Okay, B, synoptic. Okay, although a patient is on ventilator, but a patient is still synoptic. SpO2 is still low. Okay, so we need to do something. For example, increase FiO2 or increase the PIP. Okay. And also patient is still shock. Okay, is in shock. Yeah, obviously that. Okay, so a patient so we should increase the IV fluid. Okay, we might need to discuss with the doctor to start some vasopressor. Okay, for example, adrenaline. Okay, and patient is unconscious at this moment. Okay, and then the pupil is sluggish, dilated. And then we might plan to start some morphine and some infusion at this moment first. Okay. And then also again, there's some differential diagnosis. Okay. Normally, also I should ask you to give some give some diagnose here. Okay, but in order to save time, I put it here first. Okay, just for easier for discussion. Okay, for example, these are common cause of cardiac arrest, including this is 5H and 5T. I'm sure you know about this if you have done the ACLS. Okay, hypoxia, hypovolemia, hypothermia, hydrogen ion, that is acidosis, hyper or hypokalemia, toxin, tension, pneumothorax, cardiac tamponade, thrombosis cardiac, actually it means QMI. Thrombosis pulmonary, actually it means pulmonary embolism. Okay, and then some other cause might include trauma, hypoglycemia, and anaphylaxis, arrhythmia, and alcohol toxicity. Okay, I just put up some. Okay, it might you can also add some more. Okay, and then okay, here history. Okay, history. Okay, provided by family because patient is unconscious, he cannot provide the history to us or to you. Okay, onset. Patient is found unresponsive and cardiac arrest at 7 a.m. this morning. Family start CPR. The other cannot be obtained. Okay, and EMT arrived rose after the defibrillation and sent to hospital within 30 minutes. Okay, sampler. The major symptom is patient complaint of headache and palpitation after drinking a lot of alcohol, and then he fell asleep. Okay, will it be related to the alcohol? We don't know at this moment. No allergy, no food allergy or drug allergy. Medication, he did not take any long-term medication previously. And for past health, he had 2 to 3 episodes of transient blackouts over the last few months, but he did not seek medical advice. Okay, last meal, took dinner last night with alcohol. Alcohol again, will alcohol be one important factor here? I don't know. Events, he drank a lot of alcohol last night and then he complained of headache and palpitation, and then he fell asleep. And this morning he was found unresponsive and cardiac arrest. Okay, will there be any relationship? I don't know. Okay, risk factor, no high lipid, no hypertension, no diabetic, no recent travel history. Okay, so you tell me what clues can you identify here that may be related to patient's cardiac arrest? Hello? Anyone? Any information that you think is important that can help you to identify patient problem? High alcohol intake. Yes, Chris? Okay, high alcohol intake. Okay, that is okay, before he fell asleep. 2 to 3 blackout. Yeah, this is also important. Anna Carota. Okay, partial is 2 to 3 episodes of transient blackout. Okay, alcohol intake and blackout. Okay, very good. Jolan. Okay, yes. So these are also important information. So these are clinical reasoning. All the information about patient is important to help us to know more about the patient. No long-term medication. No long-term medication. Okay. Okay. So here, okay, some important things here is found unresponsive and cardiac arrest, and then symptom, complaint of headache, palpitation after alcohol, okay, 2 to 3 episodes of blackout, okay, and also he drank a lot of alcohol last night, okay. Yeah, so all these are important. Okay, we bear this in mind first, and then we move on. Okay, these information are useful to enhance our clinical reasoning later on to help us to identify patient problem. Okay, vital sign 170, blood pressure pulse 100 on volume control with respiratory rate 12, SpO2 after the L2 has been increased to 0.4, and then this is 95, temperature 36.5, sedate with M&M, what we call the morphine and midazolam, okay, and not the chocolate, okay. Okay, I assume that it is okay at this moment, okay, keep observe, okay, for the vital sign, okay, for the vital sign. And then we move on, okay. Now we, because a patient suddenly developed cardiac arrest, so we focus on the heart lung system first. Okay, if there is no attempt, and then if there is it is needed, we might also assess the other system as well. Okay, respiratory system, lung is clear, air entry is symmetrical, neck wing and normal, heart sound normal, no other sound, no murmur. Patient is sedated now, so we cannot assess the patient's conscious level, and the abdomen is soft and then no tenderness. Okay, so it seems that there is no obvious abnormal finding at this moment. So after the physical examination, okay, then we move on to the laboratory data analysis. So patient cardiac biomarker is 0.05. Okay, the blood clot indicator D-dimer is 0.3, 0.3. Okay, or 0.3, and then there's the blood gas result. Okay. So, as mentioned earlier, the CHOP I is not too bad. Okay, usually it is only significant when it is above 0.1, 0.1. So this is only 0.05. This is not significant. Blood clot indicator. So it is also within the normal range. So patient does not have any problem that is related to blood clot like pulmonary embolism. No. Okay, because there's no blood clot present in his blood. Okay. How about the blood gas? You tell me what blood gas is this? Anyone? What blood gas is this? What acid base? What I mean? What acid base disorder it is? Anyone? Hello? Any answer about this? Yeah. What acid base disorder it is? Okay, you participate more, and then this game will be more okay, more happy. Okay. Okay, what no one? Metabolic acidosis. Yes, very good. This is metabolic acidosis because the bicarbonate is low and then pH is low. This is metabolic acidosis. Actually, we can examine the BE. The BE -10 already it tells us that it is metabolic acidosis. Okay, and CO2 is normal. Normal is 4.7 to 6. Okay, so this is normal. Okay. And then PF ratio is not good. PF ratio is 250. Okay, anything below 300 is not good. Okay, so it means that the saturation, the oxygenation is still not good. Okay, hyperkalemia, Michelle, yes, very good. Patient says hyperkalemia. Okay, okay. I ask one question. What will hyperkalemia result? Tachycardia or bradycardia? If patient have hyperkalemia, will it cause bradycardia or tachycardia for hyperkalemia? Anyone? Tachycardia. Chris, any other one? Any other reply? Bradycardia, tachy. Any other? Okay, it should be bradycardia. If the potassium level is high, it will close up more sodium channel of the cardiac cell. Remember, our cardiac cell, there is a different channel or different gates. Okay, sodium channel, calcium channel, potassium channel. When the potassium is high, it will close up more sodium channel of our cardiac cell. It means that the less sodium ion will enter the cardiac cell, and then the energy level inside the cell will be less, and then it cannot give out too much signal. The signal will be lower. Okay, so the patient will have bradycardia, different form of bradycardia, including heart block or asystole. But conversely, if the patient has hypokalemia, when the patient's potassium level is low, it will open up more sodium channel of the cardiac cell. It means that more sodium can get into the cardiac cell easily, and then it can build up the energy inside the cell more easily, and then the cardiac cell is able to give out more signal, and then the patient will have different form of tachycardia, VT, VF, etc. Okay, So of course the end result is still the same. Patient will die. Patient will have a systole okay at the end okay. But remember, okay, it is just opposite. High potassium level, bradycardia. Low potassium level, tachycardia. Remember, okay, you remember about the mechanism, then you know about the reason why. Okay. Okay. Also, because the patient coming with a lot of the history, so the patient have drunk a lot of alcohol. Will the patients patient have developed alcohol toxicity before the cardiac arrest? And then we need to check test what we call the osmolar gap. Okay. And also the blood glucose is normal, so we can forget about the glucose, the reason of hypoglycemia. Okay. We come back to the osmolar gap. Okay, so have any one of you heard about this osmolar gap? Anyone? Tell me. Osmolar gap. This is to help to identify any alcoholic toxicity. Okay. What we call the osmolar gap is we use the measured serum osmol to minus calculated serum osmol. For example, the serum osmol come back is 305. Okay. And then we calculate the serum osmol by ourselves. The formula of serum osmolarity is sodium times 2 plus urea by glucose. Okay, you come back to this formula. Sodium times 2, so I give you sodium 142. 142 times 2 is 284. Okay, 284. And then plus urea and glucose. Urea is 8. Glucose is here 5. Okay, plus 8 plus 5. It is 297. Can you get it? Okay, so you will use the measured serum osmolarity 305 to minus the calculated serum osmolarity. That is 297. That is 8 millimole only, and the normal range is below 10. Okay, so that is not due to alcohol toxicity. So do you understand? So if it is above 10, it means that there is some extra what we call the active osmol, like this is alcohol inside the patient's body, and then that is the cause of patient's drop of conscious level, or it might also one of the cause that can induce the patient's cardiac arrest. Okay, but here it demonstrates that okay, it is not, patient does not have any alcohol toxicity because the osmolar gap is less is normal. Understand? Okay. And then, okay, so we come to the result here. The cardiac marker is not significant. So there is no myocardial injury. Okay. Myocardial injury include what? Acute myocardial infarction, pericarditis, myocarditis, aortic dissection. All these will produce a high troponin I level. Okay. And blood clot indicator. Okay. So there is it is normal. So it means that there is no blood clot is present in the blood. Okay, because one of our differential diagnosis is pulmonary embolism, isn't it? If I'm not wrong. Okay, so if there is no blood clot, so this nursing diagnosis can be deleted. So there is no pulmonary embolism. Okay. And then for the acid base disorder, you can know, okay, pH, patients are pH 7.1, okay, bicarbonate. So this is a metabolic acidosis. pH ratio is not good. Normally is 476. Okay, at least it should be above 300. Okay, anything below 300, the lung function is not good. Potassium is high. Okay, we know. So patient is having metabolic acidosis with hypoxemia and also hyperkalemia. Okay, so we need to watch the ECG. Patient can develop bradycardia, heart block, as a systole at any time. Okay. Okay, so the osmolar gap, so we have discussed about this. The glucose is normal and osmolar gap is also normal. So there is no alcohol toxicity. Okay, ECG time again. Tell me, what is this ECG? Tell me, what is this ECG? Anyone? Any abnormality here? Hello? Anyone? Any abnormal here, any STEMI here. STEMI where? And carota. Which lid? Which lid? STEMI. Which lid? Posterior lid. Posterior. No, there's no posterior lid here. Okay, anterior. Anterior lid. Okay. What we call the posterior lid is the V7, V8, and also V9. Okay. No. Okay. Anterior lid. Okay. V1, V2. Okay. Jolan also. Will patient has our is there a chance that patient has developed acute MI? But patient's troponin I is not high, and patient has not complained any chest pain before the cardiac arrest. Of course, there is chance of having a silent MI. I'm sure you know what is silent MI. Okay, but the troponin I level is not high. Okay, we bear this in mind first. Okay, so that there is some elevation over the patient's anterior lids, V1 and V2. Okay, so we will come back to this later on. Okay, and there is no S1QVTV syndrome, no RBBB, so that is not pulmonary embolism. Okay, if you know what is pulmonary embolism, then there is some typical feature is S1QVT3. Okay, so there is no S1QVT3 over here. Do you know what's S1QVT3? That is S in lead 1, Q in lead 3, and also inverted T in lead 3. Also accompanied by the RBBB. So there is no rapid ear here in the V1, no RBBB. So that is not pulmonary embolism. Also, we noticed that the D dimer is not high, so that is not a pulmonary embolism. Okay, so this can be excluded. Okay, and come back to here, the ST elevation over V1, V2. Will this be anterior MI? But the chop I is not high. We come back to this later. Okay, X-ray. Any problem about the X-ray? And can you see the ET tip? Is the position of the ET tip okay? And how is the lung? Is the lung okay? Hello? Can you see the ET tip? Can you see the ET tip? Is the position of the ET tip okay? You tell me. Anyone? Should the ET tip be lower? It should actually okay. Can you see the carina? The carina is here. Okay, the ET tip is here. Actually, once the ET tip has reached the clavicle level, it should be okay. Once the ET tip has reached the clavicle level, it is okay. Okay, the ET tip is okay. The lung is also okay. X-ray chest, so normal chest. ET tip position okay. It is down to the level of clavicle. It is okay already. Okay, and then okay, and then also okay. The point of care echocardiogram is done, and then the ejection fraction is 40. Okay, marginal. Okay, marginal. Okay, yeah, not good, but they're not too bad, marginal. Okay, and then there is no cardiac tamponade. Okay, so after checking the echocardiogram, there is no cardiac tamponade. Okay, there is no blood outside the heart that can compress the right atrium. Okay, if we compress the right atrium, then it will affect the venous return. But blood cannot go back to the right heart, and then the patient's stroke volume will drop. Okay, so there is no cardiac tamponade. Okay, so we all know about this. Okay, and also now we come to here. Come to this rejection part. We need to reject some unlikely diagnose. Okay, hypoxia. No, the PaO2 is okay. SpO2 is okay. Hypovolemia. No, neck vein is normal. No engorgement. Okay, and no collapse. Okay, no collapse. Hypothermia. Temperature is normal. And then toxin. No evidence the patient has drug overdose. Tension pneumothorax. Neck vein normal. Chest is clear. Chest does not show any tension pneumothorax. Cardiac tamponade. the network is normal, ECG normal, also the echocardiogram does not show any cardiac tamponade. This patient has acute MI, might be, because the ECG show ST elevation, but the chalk I is not high. Okay, we need to think about this. Hydrogen ion, yes, patient has acidosis, and also hyperkalemia, yes, patient have hyperkalemia. PE, no, because the D-dimer is normal. Also, the ECG does not show any S1QPTP syndrome. Trauma, no trauma history. Hypoglycemia, blood glucose normal. Anaphylaxis, no drug allergy history. Arrhythmia, presence of VF, okay, during cardiac arrest. Okay, this is why the EMT do the defibrillation. Alcohol toxicity, no. Although patient did drink some alcohol before cardiac arrest, but the result, the osmotic gap show it is normal. Patient does not have any alcohol toxicity. Okay, now, what is the patient's problem that induce patient's cardiac arrest? Arrhythmia, AQMI, acidosis or hyperkalemia, but acidosis and hyperkalemia should be the result of cardiac arrest. Okay, the result of cardiac arrest that can produce anaerobic metabolism, so it can cause acidosis, and also it will release potassium. So these two are not. So patient might be due to acute MI or certain kind of arrhythmia. So the ET. Okay, so anyone, do you have any suggestion? Okay. Can we come back to the ECG again? ECG again. Okay. Any one of you know about this? Okay, some people might have developed some kind of sudden cardiac arrest due to certain kind of arrhythmia. Okay, do you know about this? What do we call those? Anyone? We check the ECG. Can you see it? There's some settle back ST elevation. Settle back ST elevation. This is a typical sign of what? Brugada syndrome. You know, Brugada syndrome. That is a sudden death syndrome. It can be activated by alcohol drinking. Alcohol drinking can activate the initiation of this sudden attack of arrhythmia. Okay, so it starts with this settle back ST elevation over the anterior leg. Okay, and then out of that patient, it can induce patient developing VT and VF, and then patient will develop cardiac arrest after that. This is what we call the Brugada syndrome. Okay, so the cause is arrhythmia. Actually, the diagnosis of these patients' cardiac arrest is due to arrhythmia. That is the Brugada syndrome. Okay, so a little bit information about Brugada. Okay, this is the this problem was identified by the Spanish Brugada brothers. Actually, they have 3 brothers, but only 2 brothers involved in this work. Okay, so they found that there is some genetic sodium channel disorder which can trigger the patients developing VT and VF. Okay, what we call this sudden death syndrome. Okay, and actually there are 3 types. Okay, type 1, type 2, type 3. Type 1 is there is a small growth ST elevation. This is the number one type. This is okay. This is a sharp, tall peak. Okay, elevation with what we call the growth ST elevation. Number 2 is small a big settle back ST elevation. Number 2, like here. Okay. Okay, you can see the acceleration is higher as compared to the third one. That is a small settle back acceleration less than 1 mm. Okay. Okay, there's some more picture at the back here. Okay, this is the first type. This is what this kind of elevation is what we call the cove ST elevation. Okay, this number 2 is the big settle back ST elevation as compared to the third type is the small settle back acceleration. It happens usually over V1 to V2 or V1 to V3. Okay, and then once we detect this kind of abnormal ECG, it is dangerous. Okay, so we need to this kind of patient will need to do an urgent cardiac MRI, and then to confirm this, and also we should arrange the patient to do the ICD, okay, insertion, implantable cardioverter defibrillator insertion. Okay, that okay, so so anytime the VT wave happen again, and then the ICD can function, and then to will give the defibrillation automatically. Okay, so this is Brugada syndrome. Okay, okay, so this will activate. So the main cause of this cardiac arrest is this Brugada syndrome. Okay, which will activate arrhythmia, VT-VF, and then that can kill the patient. Okay. Okay, Brugada syndrome. Okay, the usual treatment is to give a class 1 antiarrhythmic drug, that is the clinidine, and also insertion of implantable cardioverter defibrillator, the ICD. Okay. And then more information about the arrhythmia. Okay, I know John has given you just a lecture on arrhythmia. This is just some kind of supplementary information. I don't know whether he has talked on this epsilon wave or the epsilon wave, lambda wave, and also T wave alternation. Okay, this is the epsilon wave. Epsilon in Greek means E wave or a small wave. Okay, so you can see after this, it refers to a small wave after QRS comes. That is this small wave. Okay, it is an abnormal wave related to ARVD. What is ARVD? Arrhythmogenic right ventricular dysplasia. Okay, you can see the yellow box. Okay, the arrhythmogenic right ventricular dysplasia is a rare type of cardiomyopathy. It occurs when the muscle tissue in the right ventricle dies, and then is replaced by a scar tissue, and this will interrupt the heart's electrical signal and will cause arrhythmia. Okay, so this okay, because it will cause will induce VT and VF at any time, and so again this will cause a sudden death. Okay, so again we need to do the urgent cardiac MRI and then to arrange the ICD insertion to the patient as soon as possible. Another abnormal, okay, so this again, this is the, you can see the epsilon wave, okay. And okay, epsilon wave, and then we produce the VT-VF, okay, you can see it. And then the other type of abnormal ECT that can produce life-threatening arrhythmia is the lambda wave. Lambda wave is also a quick word, okay, a quick word, okay. People use this word just because it's shape. This word look like the shape of this abnormal ECT. Okay, the ECG, the feature is there's a giant R. Okay, the R is very tall, and there is a steep down the slope ST segment. Okay, steep, very steep down slope. Okay, what we call this. So this character just like a Chinese word, enter Chinese word. I'm sure you don't know Chinese word. Okay, okay, just like enter. Okay, this one. Again, also this will elicit VT-VF, and also we need to insert the ICD as soon as possible for the patient, because the patient can have VT-VF at any time. Okay, and then okay, this is also lambda. Okay, lambda wave. Okay, like this word. Okay. And also the last one is the T wave alternation. T wave alternation. So it was identified by Keung at 1980. It also called microvolt T wave alternation, unknown cause, and also it can elicit VT-VF. You can see this picture. Okay, so there is the T wave. It change shape. Okay, all the red one are the same pattern. All the blue one are the same pattern. Okay, so T-wave alternate means that it keeps changing the shape. Okay, taller, smaller, taller, smaller. Okay, so if we note, so there's an alternate changes of T-wave. Okay, again, we find out this one, we should also do urgent cardiac MRI for the patient, also do an urgent insertion of ICD for the patient. Okay. Okay, so these are also T-wave alternates that can elicit the VT and VF for this patient. Okay, stop here. Any question about case 2? This is a case of Brugada syndrome that elicit VT-VF, and then it caused the cardiac arrest of this patient. Okay, so you can see this is the flow of the clinical reasoning. So we need to make use of all this information to help identify the patient problem. Okay, before we can select an appropriate treatment for the patient. Any question about or case 1, case 2? Case 1 is the acute MI. Case 2 is the arrhythmia. Okay, induced by the Brugada syndrome. Anyone? So you all know about this. No problem. Okay, we have 2 more cases. Let me check. Okay, I think I can only share 1 more case only because this is 4:30 already. I need to leave at 4:55. Okay, I share 1 more case and then I need to stop. Okay, then case 3, Jack, male. Jack, male 35, admitted with chest pain and shortness of breath. And now you come to assess the patient. Okay, again, chest pain and shortness of breath. Okay, again, we need to check patient because this is also an emergency situation. We need to do the primary survey first. Okay, I'll give you the answer. Okay, so patient can complain of chest pain. It means the patient airway is patent. Okay, once patient can talk, it means that the airway is patent. This is simple. Okay, breathing. Okay, patient is synoptic, and then he used accessory muscle respiratory rate 20. So patient is having hypoxia, and then we need to give patient oxygen mask. Again, patient develops shock. Okay, hypotension, rapid feeble pulse, blood pressure. Okay, marginal 90. Okay, but if you can see the skin is cold, and also the capillary refill is also longer than 2 seconds. It means actually the picture look like the patient is shocked, although the blood pressure is marginal 90. We use 90 as marginal. Okay. Of course, we still can give patients some IV fluid at this moment. No neural problem at this moment. Okay. Again, just put up any 10 dinos here just to facilitate our discussion. Of course, you can select your own. Acute MI, pericarditis, myocarditis, aortic dissection, cardiac tamponade, pleurisy, pneumothorax, pulmonary embolism, polycystitis, and anxiety. Okay, and then the history. Okay, in order to save time. Okay, again, patients have liquid ritual sternal pain. It radiate to back. Okay, it seems that radiate back. So, any idea? Any problem will have a chest pain, and at the same time, there is radiation to the back. Okay, tell me, anyone? Chest pain associated with pain radiation to the back. Hello? Hi. Any answer you can give? The chest pain radiate to the back. This is an important clue. Hello, no answer. Okay. Very tired. Oh, you. Okay. I will come to the end very soon. Okay. Medication. Patient is on anti-hypertensive drug. Okay, and he cannot remember the name. And again, patient has a Marfan syndrome, and doctor said he has hypertension. Okay, and had dinner last night. The pain come gradually over the last few days and become more severe this morning. And the risk factor is patient has hypertension, no diabetic, no high lipid in the blood, no travel history. Okay, now. Pleural effusion. What do you mean by pleural effusion? Okay, Lilibet, why do you say pleural effusion? I did not show you any X-ray chest yet. Okay, we'll come to that later. Okay, we move on. Okay, and then patient's vital sign. Vital sign is 90, 60, marginal, pulse 100, respiratory rate 20, SpO2 92. Clearly hypotension, but anyway, because the blood pressure is marginal, we can still give some IV fluid, okay, slowly, okay. And then for the tachycardia, mild tachycardia, patient has some mild tachycardia, okay. SpO2 92, then we can give oxygen mask, okay, give oxygen mask. And patient becomes has some dizziness, okay. And also patient's skin is cold and wet, capillary more than 3 seconds. Okay, is it shock? Okay, not okay. And then all this shock presentation. Okay, anyway, we have started IV fluid. Okay, can you tell me any problem here? Okay, respiratory system, rapid breathing, chest clear with air entry bilateral symmetrical, percussion note on both sides equal, no proflexion wrong. Engorged neck wing, rapid and weak HACSAM. Neuro alert but dizzy, pupil equal and relative to life 3 mm. Abdomen, query thick, very thick, abdominal discomfort, Murphy sign negative, that is what? No cholecystitis, no cholecystitis. Neuromuscular, musculoskeletal system, no finding. And other system, left arm blood pressure, 105. Right arm blood pressure, 90. Can you tell me what problem? What have you identified? Anyone? Anyone? Hello? You focus on the blood pressure. The right side is lower. The left side is higher. Okay, engorged neck wing. Engorged neck wing means that the heart is not pumping. Usually 2 meaning. Engorged neck wing is either means high CVP or hypervolemia and also or heart failure. Okay, heart failure. Okay, that is the heart is not pumping good. Okay, Michelle, aortic dissection. It might be. Okay, might be. Because number 1, patient has chest pain, radiation to the back. Remember. Number 2, when we compare the blood pressure on both sides, the right arm is lower, the left arm is higher. Okay, this is important sign. Okay, blood pressure, yes, Jolan, blood pressure difference on both arms and engorged neck wing. Okay, okay, so engorged neck wing might be a possible blocked artery. Okay, possible blocked artery. If there is blocked artery, it will block the right arm. It means that, okay, there are 2 meaning. Okay, if we compare the both arm, okay, one side higher, one side lower. Okay, we believe, we trust the higher one because we believe that the lower one is caused by some blocked artery. Okay, but here, because at the same time patients have chest pain, radiation to the back. Okay, it is very compatible with aortic dissection, and also it is supported by the blood pressure difference here. Because if there is an aortic dissection, because the left side is more close to the aorta, so the left side is always higher than the right side. Remember, when there's aortic dissection. Okay, so this is also important important hints. Okay, so we don't just focus on the blood pressure difference. We also look at the physical examination finding. Okay, we can carry on. Okay, so the left arm or the blood pressure difference can be due to full sclerotic right arm, such as that is what you mean, John. Okay, that is sclerotic. Okay, or aortic dissection. Okay, Jolan. Yeah, yes, that's definitely okay. So if it is due to if there is only blood pressure difference alone, okay, it might be due to either one, aortic dissection or the atherosclerotic right arm. Okay, but patient also develop the chest pain and radiation, pain radiation to the back. Okay, back. Okay. Also, there is some engorged neck wing. It means that the heart may be compressed by something. Okay, we move on first. X-ray, of course, there's X-ray. We go to the X-ray later. Jolan. Okay. Okay. 41 now. 441. Okay. Okay. Cardiac biomarker. Okay, that is is high. Cardiac marker is high. Okay, and then blood clot indicator is normal. Or the D-dimer is normal. Blood gas. Okay, we move on more quickly. Okay, so the cardiac marker is high. It may reflect myocardial injury. Okay. And the blood clot, the D-dimer is negative. Okay, negative. Okay, and then for the blood gas, again, this is a mixed acidosis. Okay, high CO2 and low bicarbonate will also cause acidosis. This is mixed acidosis, and also patients' PF ratio is low. Okay, actually, PF ratio is good because it is a more objective data to reflect patient's oxygenation. Because if we just talk about the PaO2, because you need to consider what oxygen percentage patient is on. Okay, if say you say patient have a 60 mmHg. Okay, if patient on room air on 100%, the meaning will be very different. Okay, so PF ratio is very good to reflect patients' oxygenation in a more objective way. Okay, so patient have mixed acidosis and also hypoxemia. ECG. Okay, who can tell me any problem about this patient ECG? Any problem? Any problem you can identify? No. Okay, low voltage. Low voltage. Okay. What we call low voltage usually we refer to the limit lead 1, lead 2, lead 3, AVL, AVL, and AVFR. So the amplitude cannot exceed 1 Beck square. Okay, but for the limit, it is difficult. Usually because the left ventricle is thick, so usually it exceeds 1 Beck square. So we usually we refer to those limit. Okay, low voltage. Okay, they can so there's absence of MI. There's no MI here, no pericarditis, no myocarditis, and no pulmonary embolism because there is no S1QPTV syndrome, no ST elevation, so no MI, no pericarditis, no myocarditis, just low voltage. What can cause low voltage? Tell me, what can cause low voltage? Low voltage ECG. Usually, other than COPD, for cardiac problem, usually when there is something surrounding the heart, okay, that reduce the what we call the short circuiting, that reduce the uptake of the ECG signal, that will cause the small amplitude ECG. Okay, so remember the low voltage ECG. It means the heart, there may be something surrounding the heart, okay, that block the electrical conduction, that make this small size ECG. Okay, there is an X-ray here. Can anyone tell me what is this? Okay, last 10 minutes, I must go for another appointment. Okay, what is this? Can anyone tell me what is this? Okay, pneumothorax. This is not pneumothorax. This is not pneumothorax. Can you see here? What is this part? What is this part? What is this part? This is not pericardial effusion. Effusion is fluid. It will drop down to the diaphragm. You can see all the diaphragm are so clear. Okay, not filled with fluid. If they you mean pericardial effusion. Okay, no pericardial effusion. If there is pericardial effusion, okay, might be. We talk about this later on. You tell me, what is the difference between pericardial effusion and also cardiac tamponade? Anyone? What's the difference between pericardial effusion and cardiac tamponade? Tell me. Pericardial effusion is the collection of fluid or blood in the pericardial sac. Okay, and then what is cardiac tamponade? Anyone can tell me? No. Cardiac tamponade, yes, it causes compression. When the fluid collection inside the pericardial sac increases to a certain extent that it compresses the heart, and then the heart cannot contract properly, and the blood pressure drop. That is cardiac tamponade. Okay, back to here. Actually, this is what we call the widened mediastinum. Widened mediastinum. Okay, this is widened mediastinum. What is this? Can you show my watch my cursor? What is this? This is the anyone. Some of you mentioned this diagnosis previously. What is this one? This is aortic. What was it? This is aortic dissection. This okay, this zone, this whole zone is the aortic dissection. This is the dissection of the aortic wall. What you can see over all this zone is the blood collection inside this part. The blood collection or inside this part. This is the aortic dissection. Okay. And also this is the echo. Echo. The ejection fraction is low, 35. Okay. What can you see in this echocardiogram? What can you see? CT forest will also be arranged and will be done soon. Okay, so if you don't know how to read this echocardiogram, I show you. Okay, you look at this picture. This is left ventricle, left atrium, right ventricle, right atrium. Okay, outside the right atrium, you can see the dark environment. That is the blood. The blood compressed on the right atrium. The right atrium is collapsed now, so no blood can get into the right heart. So the venous return drop. So that is why the blood pressure drop. This is what we call the what do we call this? The blood compressed on the right atrium. Blood cannot go back to the heart. What do we call this? This is cardiac tamponade. This is cardiac tamponade. Okay, so patient has a cardiac tamponade. Okay, and okay, and also, so the ejection fraction is low. There is cardiac tamponade. And the thoracic, so thoracic, well, I can Mr. That. Let me show. I have high up the actually. Let me check. Can you see this? Can you see this is on the screen? This is a CT fluorescence. This is the aorta. Can you see? Okay. So this one. Okay. TL is the true lumen. DL is the dissected lumen. Can you see? So this is definitely thoracic aortic dissection. Okay, thoracic aortic dissection. Okay. Okay, so now the answer is more clear now. Okay, so this is not a QMI because it's the ECG, no ST elevation, pericarditis and myocarditis not compatible because there's no generalized ST elevation. Okay, pleurisy, no pain during inhalation, pneumothorax, no, X-ray normal, pulmonary embolism, no, D-dimer is low, and also no ECG, no S1QVT TV syndrome, cholecystitis, no, Murphy sign negative, no anxiety, and then what is left is aortic dissection because the CT forest show aortic dissection, and also the pain radiate from the chest to the back, and also there's some difference in pressure both arms. Remember, when there is aortic dissection, because the aorta is more close to the left side, so the left arm's blood pressure will be higher than the right arm. Remember, okay. And also the cardiac tamponade, okay. So the echo findings show that there is the right atrium compression. This is cardiac tamponade, okay. A compression on the right atrium, then blood cannot go back. So the venous return drop, and then patient's blood pressure will drop. Okay, so this cardiac tamponade is due to the tear of the aortic thoracic aortic aneurysm. Okay, so this is the thoracic aortic dissection, and also the cardiac tamponade causing the obstructive shock. This is the refined diagnose and also the final diagnose. Now, and for the treatment for the cardiac tamponade, of course, we need to treat the shock first, the obstructive shock first, and also we need to do the needle aspiration under echo guided, okay, to aspirate the blood out. Of course, the most important thing is to manage the tearing of the aortic thoracic aorta. Okay, that is the thoracic aortic dissection. Okay, so if for the medication, we need to give drug to control the blood pressure to prevent further deterioration, and also we need to consult the surgeon for surgical repair. Okay, and that is okay. Okay, I think I don't have time to do the last case because I have an appointment in 10 minutes time. Okay, so any question? I hope these 3 cases can help demonstrate the use of the clinical reasoning, the flow of clinical reasoning to manage cardiac emergency, and I hope it is useful to you. Thank you very much. Okay. Any question you can ask? You can, yes, you can write in the chat box, or you can, yes, or you can just ask me. Any question? Okay, no question. If no question, then thank you so much, and I hope this sharing is useful to you. And I hope okay. So there's my IG here. Look at my IG. There's a lot of medical information. I put a lot of medical knowledge inside. You can share it. Okay, or you can ask me any question related to intensive care, disaster trauma, medical simulation. Okay. So I hope Dennis or John or Professor Rogato will invite me again to do some more sharing with you all in future. I'm happy to do so. Okay, free of charge. Okay, Dennis. Okay, I finished my talk. Okay, I hope it is useful to them.
Thank you, Professor David, for sharing your expert thoughts on clinical reasoning in cardiac emergency.
Yes.
So,
No more
should
question?
you have any questions,
Okay.
clarifications, reactions, or any kind, you may now type it in
Okay.
in the chat box.
Yeah. You can ask now or in the chat room, or you can see my email navigator. You can send email to me, or you can add my IG, and then you can ask me question on the Facebook or IG or through my email. I'm happy to answer your question. Okay.
So, Professor David, there's
Just Dennis just call me David. It's okay, David.
okay.
Yes. Yes.
Sir David, there is one question here for there are hospitals in the Philippines who still do not have morphine sulfate. What will be its substitute in case it is not available at bedside?
You mean some hospital in Philippines do not have morphine? Okay. So what do you use morphine for? For managing the pain during acute MI or what?
Yeah, usually we use morphine sulfate for management of chest pain for acute MI.
Yes.
So there are some hospitals in the Philippines who still do not have morphine available at bedside.
Then
so
what do you
substitute?
Okay. Then what do you use if you don't use morphine? Usually for chest pain, we can use the GTN first. The GTN for up to 3 doses. If it does not work, and then we use morphine. But if you don't have morphine, normally what do you use? Currently, what do you use? Dennis? Okay, Dennis, can you hear me?
Yes, Professor.
Yeah. If currently you do not have morphine in the hospital, what do you use to manage patients' chest pain other than using the GTN?
There are some hospitals like us who utilizes other pain relievers such as tramadol or sort of other pain relievers other than if there is no morphine.
Okay. So for the medication part, I think it's better to refer to your own doctor, because different hospital, different doctor might have different preference. Okay, so I think you should consult your own doctor. Yes.
Okay. Thank you, Professor.
Okay, thank you, Dennis. Okay, so if no problem, I need to leave now because I will have an appointment at 5 p.m. Okay, so thank you all of you. Thank you, Dennis. Thank you, John, and thank you, Belle. Okay, so I'm leaving now.
Thank you, Professor.
Thank you, Dennis. Okay, so thank you all of you. Bye-bye. Bye-bye.
Bye. At this juncture, I would like to present the certificate of appreciation to Professor David.
Okay.
The certificate reads Critical Care Nurses Association of the Philippines awards the certificate of appreciation to Professor Chan Wing Keung David.
Yes.
For being our speaker during the online course on World Heart Day 2023, a nurse's role in acute coronary syndrome, with the topic Clinical Reasoning in Cardiac Emergency, conducted via Zoom platform on September 29, 2023. signed by John Christian M. Agustin, RN, Sinapi Vice President, and Maria Isabelita Sirugado, MAN, RN, Sinapi President.
Okay. Thank you,
Once
Dennis.
again, thank you, Professor.
Okay. Thank you for this certificate of appreciation. Okay. Thank you so much. Bye-bye.
Bye-bye. Again, I would like to emphasize that this webinar is applied for CPD credit units to the PRC Board of Nursing. And please take note that this will be the template of the certificate which you will be receiving. The program accreditation number and the CPD credit units will be emailed to you once available. The certificate will be sent to your email once you have taken the post-test and answered the evaluation of this program, which will be given to you at the end of the webinar. For the reminders and upcoming courses, I would like to invite everyone to please attend the upcoming webinar on care of patient on mechanical ventilator on October 18 to 20, 2023 from 8 o'clock in the morning to 3:30 in the afternoon via Zoom platform. This is a 3-day learning course designed to provide the nurse participants with vital concepts of mechanical ventilation that is essential for a critical care nurse to be equipped with and be able to provide efficient and safe care. Moreover, the 15-hour program will help nurses develop critical thinking in care of patients with mechanical ventilators, guided by up-to-date evidence-based practices that focuses on patient safety, patient comfort, pain management, and sedation. On November 7, 8, 9, 10, 13, and 14, 2023, there will be an online course on essentials of critical care nursing or ECCN from 1 o'clock to 5 o'clock in the afternoon. This program is a 24-hour course intended to provide the nurses with an overview of critical care nursing practice. The course will present the physiological concepts that will be the basis of understanding the most common illnesses that is related to cardiac, respiratory, and neurologic system in an adult population and the common reasons for pediatric hospitalization. This course will offer an opportunity for nurses to develop critical thinking by integrating knowledge about disease assessment, nursing intervention, and collaborative management. Likewise, I would like to invite everyone to be a member of Sinapi to enjoy discounts to our upcoming trainings and free updates. Just log into our website, sisinapi.org, under the membership tab for further details. So the link for the evaluation is now accessible. Please scan the QR code, flash on your screen, or click the evaluation link at the chat box. For other information and concerns, please feel free to email us at ccnapi@gmail.com. At this point, Sinapi would like to thank everyone, especially to our speakers, for sharing their expertise, and to our participants for attending this online session in celebration of the World Heart Day 2023. This has been Dennis Tawataw, your online moderator. Thank you and take care, everyone. God bless.